Anil, let me know when to start.
Good morning, sir.
Morning,
Good
everybody.
morning.
Hello, sorry. So I welcome you all to the annual chapter of Maharashtra State AROI 2020. So this is going to be an online virtual meeting. First of all, I would like to invite Dr. Sonali Pingle, who is the current Joint Secretary of MSRI, to welcome and for the introduction of this meeting. So over to you, ma'am.
Good morning, everyone. It gives me great pleasure to invite everybody for this online portal, online meeting of the AROI Maharashtra chapter. The online port, we had to restore to this module in view of, as you all know, in view of the current pandemic. And let me hand over the proceedings to Dr. Virendra Vyas, who is the president of our MSRI Maharashtra chapter.
Sir, you are muted. Dr. Vyas. Sir, you are
Vyas,
muted.
we can't.
You are muted, sir. We are not able to hear you. No, sir, we are not able to hear you.
अनिल तुम उनको अनम्यूट कर दो ना.
Sure, ma'am.
And now you can hear me?
Yes, sir.
So, good morning, everyone. On behalf of Maharashtra chapter of AROI, I welcome you all. Though every year we are arranging a conference with very lively participants and very highly academic presentation. But this year, due to a sad pandemic, we are doing a virtual conference, and I hope everybody from the Maharashtra chapter are participating in it. Fortunately or unfortunately, our dynamic secretary Umesh is not here, but I welcome him. Is he here? Because he is still our member. Umesh is there.
Umesh is not here right now.
Okay. So I welcome you all, and we start our proceedings. And I hand over the proceeding to the our organizing secretary Anil Tibdewal. Anil.
Sure, sir. Thank you, sir. So before we start our proceeding, I would like to invite Dr. JP Agarwal, sir, to welcome all the delegates and the presenters for this annual chapter. Over to you, sir.
Thanks, Anil, for arranging this beautiful meeting. I think this is going to be new normal. And actually, it has become a new normal. It has its own advantages, disadvantages too. And as I think I have echoed some point of time, we will be having something like a hybrid meetings in future, online as well as physical. Without taking much time, welcome everybody, and being TMH as the host, it's a pleasure to welcome you all on this online virtual meet. And I hope you will enjoy this short but a great academic feast by youngsters, and they have really put a hard work of theirs. And thank you very much to come on a very short notice. Anil, please take care. and take over. Thank you, everybody.
Sure, sir. So before we start, I would like to highlight the program as all of you have received the program. So I'll just highlight that we will be starting soon with the head neck oncology. So it will be, we have given this opportunity of the MSRI basically for the postgraduate and the young radiation oncologist. So the idea behind this annual chapter was to promote the young radiation oncologist of India, especially the postgraduate student and the young senior residents of the Department of Radiation Oncology of the entire state of Maharashtra. So first session will be on the head and neck oncology. The second will be on the neuro-oncology. Each session will be of a duration of 45 minutes. There are 2 or 3 presenters in each of the sessions. And then we will have a tea break after the session of the neuro-oncology, in which the e-poster will be displayed. Each poster will be displayed for 2 minutes. I would request all the e-poster presenter to be present at the time of the tea break. Be it in virtual, don't go anywhere else. So this tea break is only virtual, and then we will have the session on the breast oncology, and after that we will have a session on the thoracic oncology. I would request everyone that if you can mute your audio off, and please do not speak in between, and so it will be easier for us to streamline our session proceeding, so without any hassle. So we are just waiting for our dynamic secretary, Dr. Umesh Mohan Shetty, to join. I would want him to have a word with all of you. Umesh sir, have you joined? Dr. Umesh Mohan Shetty?
Anil, I'm there.
Yes, sir. Good morning to you.
Morning. Nice to see you all.
You are welcome.
Thank you, Dr. Bass.
So we just had an introduction of the meeting, sir, and Dr. Virendra Das, Dr. and Dr. JP Agarwal has already spoken. So we would want our current secretary, Dr. Umesh Mohan Shetty, to welcome you all.
So apologies for joining late, and thank you very much for keeping me in the loop for this meeting. I'm not sure whether everybody knows, but I have relocated from the state, but on popular demand from our president, I have been still continuing in this meeting, and I would love to hear from our young people. And I think fantastic job has been done by Dr. Anil, Dr. Sonali, President, and Dr. JP Agarwal to come up with this virtual meeting this year. And maybe this meeting will bring some good luck from 2021 onwards, because Maharashtra chapter has been having a tough time for a couple of years now. So my best wishes to all, and please go ahead and start the session, Anil. Thank you.
Sure, thank you, sir. We have also been joined by Dr. Sarbani Ghosh Lashkar. So I would also like her to speak a few words. So before we start the session, as we have some time to start the session, officially we are starting at 9:30. So I'm still waiting for my chairpersons to join for the first session. So in that period, so madam, please.
Thank you, Anil. But I think both of us moderators for the session are very much here, both Nikhil and I. Thanks, Anil, for organizing this and doing all the legwork. You and Anuj have done a great thing, and I think the rest of the organization has pitched in to help us conduct this meeting. So once again, welcome all of you. Stay safe, and hope we'll have a good new year at least. So that's the only thing that we can hope for now. And Anil, let us know when we can start the head neck session.
Everybody can switch on their video and take a group one. Is it a time? At least.
Yeah, if everybody is there, just switch on your video, all of you. Anil, tum kidhar gaye?
Yes, sir, I am here.
Who are the others? Rahul, Tesina, Meenakshi, Megha, whoever is on this, can you please come on? Want to see your faces. Who is Nanki Bakshi? Megha, Mahavar.
They are from Lomi, if I correct.
She is a
Want to see
presenter.
your faces. The TMH group, will you sit together with your masks on?
Most important.
Prachi, sit.
बाप रे बाप.
प्राची थोड़ा नीचे हो जाओ ना प्लीज. तो
फोटो के लिए तो मास्क निकालो.
नहीं ठीक है चलेगा.
न्यू नॉर्मल फोटोग्राफ्स क्या?
Yeah, these are new normal. Okay, are we ready? Rabi, who's sitting behind Rabi? Come a little bit in front, Babusha. Dr. Vyas, please बैठ जाइए.
Yes, Sarvani.
हाँ हाँ सर आप बैठ जाइए, आपका फोटो निकालना है.
अच्छा.
Anil, who's next to you on the other side? Is that Sheetal?
Sheetal.
Yeah, थोड़ा सा अंदर आओ शीतल. Yeah. Okay, ready?
Yes.
Ankur, can you sit in a little bit of light? Come a little to your left. Yeah. Ankur, बैठो. Don't go out, but yes, sit in a little bit of light. Your face is in completely dark. Who is Rahul? कहाँ गए तो? चलो. Okay, ready?
Yes.
ये अंकुर तो बिल्कुल काला हो गया.
Say cheese.
अंकुर भैया बैठो.
Go on taking photographs, Sarvani.
One done. Hi, smile. 1, 2, 3. Chalo, done. Let's start.
Where is Professor Lashkar?
He's not there. He's gone to Guwahati.
Okay.
Hi, Trinanjan and everybody. Good. Ankur, I can see. Good,
Hi, sir. Good morning.
Good morning to everybody. चश्मा बड़ा हो गया लगता है.
You are looking like Shankar man.
Oh, please. This is too much.
शंकर को भगा दिया तुमने.
But you think I have that capability?
शंकर को भगा दिया त्रिनंजन ने.
आप ये ऑफिशियल मीटिंग में गलत कमेंट कर रहे हो.
अभी राहुल को बोलता हूँ बोलने के लिए.
It's okay.
Good morning, everybody.
Rahul,
Actually, Doctor. Good
Trinanjan को
morning,
बोलो
sir.
कुछ.
Actually, Dr. Umesh sir is pulling everybody to towards south.
That's a good one.
राहुल कुछ तो बोलेगा.
Anil,
attraction power है.
should we start?
उमेश किसको और भेजू?
So we'll be
Everybody is
starting.
welcome. Yeah.
So in the meantime, you can have your morning pleasantries.
Chai, coffee.
Should we start, Anil?
Yes, sir.
Anil, चालू कर.
Starting soon. Just a minute.
Okay, great.
Just excuse me for 2 minutes.
Yeah.
कौन है बंगाली कौन बोल रहा है?
Hello, whoever is not participating in the meeting, please mute yourselves.
So with the permission from our secretary and joint secretary and president, so we'll be starting the session. So before we actually start the session, I would like to invite Dr. Anush Kumar, who will give you all just a brief of rules and regulation for the morning proceeding. So over to you, Anush.
Very good morning, everyone. So we'll be starting with our session soon. So today we will have, in the first session, we will have head neck oncology followed by neuro-oncology. Then we'll have a tea break and e-posters will be displayed during that time. And after that, we will have the breast oncology and the thoracic oncology sessions. So we have generated a Zoom link and a YouTube link for more people to attend the conference. And there is provision of asking questions both through the Zoom meeting chat and also through the YouTube chat. So any questions during the time of presentation can be asked in the chat box, which will be replied at the end of the session. And I request all the participants other than the speaker to mute their audio during the time of the presentation, and any questions to be please asked at the end of the presentation. So this is the general rules for the meeting. So I would like to now hand over the proceedings to Dr. Babusha, who is a senior resident in our department, to invite the chairpersons for the first session of head neck oncology. Thank you.
Good morning, everyone. Starting the session of head neck oncology, I would like to invite the chair people. Dr. Girish Bedre is the first chairperson for the head neck oncology session. He is a practicing radiation oncologist for over 12 years at Sri Guruji Rugnale and has a vast experience in the subject. He has joined the meeting already. The next chairperson is Dr. Trinanjan Basu. He is a consultant at HCG Borivali, Mumbai, and has a keen interest in head and neck cancer. I would like to invite both of them to invite the experts for the session.
Thank you. First of all, thank you for calling me in this MS AROI meeting and inviting me as a chairperson. It's a great pleasure to be a part of TMH meetings always, and thank you for that. So without wasting much time, let me introduce the today's presenters. For this head and neck session, the expert comments will be given by the experts are Dr. Nikhil Kalyani and our own beloved Dr. Sarbani Ghosh-Laskar madam. So I invite both of them. Please join. The first topic is on outcomes of adjuvant IMRT in oral cavity cancers, an audit of institutional practice by Dr. Rabi Das. The time allotted is 7 minutes, so I request all the speakers to be within the time. Thank you. Dr. Rabi Das.
Can you see the screen?
We can see.
Okay.
Rabi, can you just introduce yourself?
Yes, sir. Good morning, everyone. Myself, Dr. Ravi Shankar Das, Junior Resident, Tata Memorial Hospital, Mumbai. I will talk about my thesis, that is outcomes of adjuvant IMRT in oral cavity cancer, an audit of institutional practice. So, standard of care of oral cavity cancer is surgery followed by appropriate adjuvant therapy with the curative intent. And there are at least 7 randomized controlled trials which have shown that IMRT has a better outcomes in terms of local recurrence as well as toxicity profile as compared to the 3D CRT or conventional. But there is positive literature in the extrapolation of the same effect of IMRT in the post-op setting. Besides that, there are some of the issues of adjuvant IMRT, that is, there is no definitive definition of target volumes. Issue of marginal failure is there, and post-op distortion of the anatomy of the primary, and dose to the flap and the effect on that on the recurrence. So my aim and objective are to evaluate the outcomes of adjuvant IMRT in terms of local control, locoregional control, disease-free survival, overall survival, and toxicities. So coming to the inclusion criteria, we have included all the patients of age between 18 to 75, biopsy-proven, non-metastatic, untreated head and neck squamous cell carcinoma at non-nasopharyngeal and non-sinonasal sites who underwent surgery with radical intent, who are treated with EBRT using IMRT technique in TMH or outside if all the details of adjuvant therapy are available. with at least having one follow-up after the receiving RT or CT-RT. And we have also included the patient who underwent surgery after NSCT. Coming to the exclusion criteria, patient who underwent debulking surgery but not in a radical intent, with where the detailed pathology report of head and neck malignancy was not available, or the post-op RT details were not available, and the patient who all were treated with EBRT with conventional technique and who had received brachytherapy and who did not complete the treatment were excluded from my study. Coming to the contouring principles, the CTV 60 or 64, that is high-risk CTV, include the tumor bed plus pathological involved nodal level. Whenever available, the pre-op imaging was fused and co-registered with the planning scan, but the flap was not an intentional part of the CTV. PTV high risk will be the PTV high risk was the high risk CTV plus 5 mm margin, and the dose was escalated to 64 gray in the presence of positive close margin or the gross external extension. Coming to the CTV low risk, the remaining neck nodes failed to be at the risk of recurrence were included. It depends upon the primary site, local disease, and extent and nodal stage. Like for lateralized gingivobuccal tumor, only the ipsilateral nodes were included. In contralateral nodes are included for elective irradiation only. In case of oral tongue or floor of mouth primary, GBS tumor that cross the midline, level 1A involvement, and where the extensive involvement of level 1B, external extension is there. Similarly, PTV low risk will be PTV low risk was the low risk CTV plus 5 mm margin. So 113 patients were included who all were treated between Jan 2010 to June 2020. Time to events intervals were calculated from the date of surgery to the events of interest, that is last date of follow-up or death. Overall survival was calculated at the interval from the surgery until the death from any cause. DFS was calculated at the interval from the date of surgery to any disease-related events or death from any cause. Similarly, local regional control was calculated from surgery to local or regional recurrence. Distant metastasis-free survival was defined as the surgery to the distant mets. And coming to the material method, at recurrence, imaging with recurrent tumors was fused with the treatment planning scan, and the recurrent disease was delineated and classified into 3 types of recurrence, that is infield, marginal, or outfield. It was said to be infield if more than 95% of the recurrent disease volume was within either high risk or low risk CTV. Similarly, marginal if the volume was 20 to 95%, and outfield if the recurrent volume, the overlapping volume is less than 20%. Coming to the demographics, the median age of the population in my cohort was 51 years with 77% male, and about 84% had addiction of either tobacco, alcohol, or smoking.
3 minutes left.
Coming to the disease characteristics, most of the patients were of PT2, pathological stage 2, T stage 2, followed by T4 and T3. And about 63% patient was of tongue and floor of mouth primary, and 37% had vocal complex primary. And about 52% had node positive, node negative, and 18% had M3 disease. About 56% patient had received surgery followed by EBRT, and about 1/4 of the patient had received surgery followed by CTRT. All patients had neck dissection, and about 23% of the patient had bilateral neck dissection. And the median radiation dose was 60 gray. Median time to start RT was 52 days. Median treatment package time was 91 days. Coming to the outcomes and patterns of failure, with a median follow-up of 21 months, the estimated 2-year local control, local regional recurrence-free survival, DFS and OS were 90.5%, 86%, 73%, and 85% respectively. Coming to the patterns of failure, about 17 patients had relapse or record, out of which there were 5 local failure, 1 local regional failure, 2 regional failure, and isolated distant failure was 7, and 1 patient had both local as well as isolated distant failure, and 1 patient had regional as well as distant failure. So out of 10 patients who had local regionally record, 70% were infield recurrence, 30% were outfield, and there were no marginal recurrence observed. And of the 7 infield recurrence, 6 were within the high risk CTV, and 1 was both in high risk as well as low risk CTV. As you can see in the CT, the area covered by the green line is the high risk CTV area, and the blue area denote the recurrent volume. It is inside, wholly inside the CTV, so it is an infield recurrence. Similarly, the blue area is the recurrent volume disease, and the green line, the area covered by the green line is the high risk CTV, and the pink line denote the overlapping volume, which is less than 20%. So it was an outfield recurrence. Coming to the univariate analysis, it was evident that higher PT stage, higher N stage, and the patient who had ENE positive had a significantly lower outcomes as compared to the patient who did not have those. As you can see in the Kaplan-Meier curve, patient who had higher N stage had a significantly less locoregional recurrence survival as compared to the patient who had the nodal stage N0 or N1, and similarly, patient who had ENE positive had a significantly less 2-year locoregional recurrence survival as compared to patient who did not have extranodal extension. Coming to the multivariate analysis, again, the patient who had a higher nodal stage had a significantly less locoregional recurrence survival, and you can see.
Rabi, please finish in time.
Yes,
you
sir.
Already overshooted your time.
Yes, sir. I'm finishing. Coming to the disease-free survival, again, the higher T stage and higher N stage had a significantly lesser lower disease-free survival as compared to the lower stages. And again, in the overall survival, higher PT stage had better overall survival, and trends was significant. Trend was significant. So finally, coming to the toxicities, the grade 3 or more acute toxicities of skin was acceptable, that is 1.8%, with mucositis of 5.3%, and there was no grade 3 or more xerostomia with acute dysphagia of 2.7% at 2 years. And the late toxicity, the grade 2 or more late toxicity is around 7.7% in skin, and about 4.5% mucositis with 5.3% dysphagia and 2% subcutaneous fibrosis, and the xerostomia was around 10.5%. That is, it is more than grade 2 late toxicity. So finally, the acceptable locoregional control was achieved in the oral cavity cancer patient with post-op IMRT. And there was no increase in the incidence of marginal failure. In my cohort, there was no marginal failure there. And IMRT, so IMRT could be the standard of care for post-op oral cavity cancer due to the potential to reduce the toxicity and the improve survival. Thank you so much.
Yeah, I think should we take the questions later? Hello.
Yes, sir. We'll take the questions in the end after all three.
Is my co-chair is there, Dr. Trinanjan?
Sir.
Please introduce the next.
Yeah. Sure. So the next speaker is Dr. Sheetal Kashit. She'll be talking on clinical outcomes of consecutive patients of primary oropharyngeal squamous cell treated with radical radiation with or without concurrent chemo. And her time allotted is 7 minutes.
Correlation of O6 nucleic acid DNA till transfer gene
Good morning, everyone. The topic of our study was clinical outcomes of consecutive patients with primary squamous cell carcinoma of oropharynx treated with radical radiotherapy with or without concurrent chemotherapy. So today there is worldwide increasing incidence of oropharyngeal carcinoma. Single modality, that is radiotherapy or surgery, is the standard of care for early stage, while combined modality, chemoradiotherapy or surgery followed by adjuvant therapy, is the standard of care for locoregionally advanced cancer. Treatment of oropharyngeal carcinomas can significantly impact the patient's quality of life. Hence, treatment strategy should aim at maintaining the high cure rates while minimizing the long-term treatment-related toxicity. In India, most patients present as locally advanced disease. Worldwide, increasing incidence of HPV-positive oropharyngeal squamous cell carcinoma is there, while tobacco-related oropharyngeal cancer incidence is decreasing. Almost 65 to 75% of the oropharyngeal cancer in Western countries are HPV-associated, while the same amounts to only 15 to 22% in developing countries. Most common subtype is HPV-16, which is associated with oropharyngeal cancer. This HPV-associated oropharyngeal cancer presents at younger age and associated with excellent prognosis. Given the excellent prognosis, various studies have been done before, which has showed that HPV-positive oropharyngeal cancer have excellent local control, progression-free survival, and overall survival irrespective of other factors. So, given the good prognosis in HPV-related oropharyngeal cancer, world is moving towards de-escalation today. But there is no large data available on HPV status in oropharyngeal cancer for Indian cohort. Also, the outcome of oropharyngeal cancer remains poor in Indian scenario. So this study will help us to design the future trials for dose escalation or dose de-escalation based on the incidence of HPV status in Indian scenario. So aim of the study is to study the clinical outcomes of consecutive patients with primary squamous cell carcinoma of oropharynx treated with radical radiotherapy with or without concurrent chemotherapy. The primary objective is to study the local control and local control. Secondary objectives are to study disease-free survival and overall survival, as well as the rate of HPV positivity in Indian cohort, to study clinical outcomes with respect to HPV status, and to study various other demographic, patient, disease and treatment related prognostic factor, to study differences between outcomes in conventional radiotherapy and IMRT, and to report toxicity and pathogenicity. The inclusion criteria is histopathological diagnosis of squamous cell carcinoma of oropharynx patients treated between January 2013 till December 2017, all from stage 1 to stage 4, and treated with radiotherapy with or without concurrent chemotherapy. Exclusion criteria was patients who were treated with palliative intent and who were referred outside for radiotherapy. The sample size was 630 patients. Duration of study from 2019 to 21. It is a retrospective observational study. Descriptive analysis was done for demographics, while Kaplan-Meier method was used for survival analysis. All the events were calculated from the date of diagnosis. So 4,998 patients who were treated under head and neck DMG from Jan 2013 to December 2017 were screened. Out of that, 1,080 were of oropharyngeal cancer. The 630 total patients of oropharyngeal cancer meet the eligibility criteria for the study. Coming to patient characteristic, the median age at presentation was 56 years. Most of the higher incidence was seen in male. Most of the patients were of good KPS. Almost 87% of the patients were of advanced stage 3 and stage 4. Most common subsite was base of tongue and vallecula, 46%, followed by tonsil, soft palate and posterior pharyngeal wall. P16 status by immunohistochemistry was available for 297 of the patients, out of which only 37 patients, amounting to 12.5%, were P16 positive, while 87.5% patients were P16 negative. Most common treatment modality used was chemoradiotherapy. The median dose of radiation was 70 gray. 92.6% of the patients received more than 66 gray. The almost 3/4 of the patients were treated with conventional technique. IMRT was used for 25% of the patients. Coming to results, the median follow-up of 43 months, the median overall survival was 65 months. At 3 years, it was 59.5%, and at 5 years, 51%. The median local control was 46.5%, 46.5 months. At 3 years, it was 51.8%, and 5 years, 48.5%.
2 minutes more for you.
Yeah. median loco-regional control was 12.6 months. At median, at 3 year, it was 39.1%. At 5 year, 35.9%. Disease-free survival, median disease-free survival was 11.7 months. At 5 year, it was 26.5%. So coming to outcomes based on HPV status, the local control, disease-free survival, and loco-regional control was significantly better in P16 positive patients as compared to P16 negative. While there was no significant difference between overall survival in P16 positive and P16 negative patients. So the conclusion, the incidence of HPV positive cancer is only 12.5% in our series. While this group has excellent prognosis, there may be need for treatment escalation strategies for HPV negative oropharyngeal cancer. Thank you.
So thank you. The next topic will be presented by Dr. Pallavi Kalwande. The topic is palliative radiotherapy to triage patients for radical treatment in locally advanced head and neck cancers during COVID-19 crisis. The time allotted is 5 minutes. Dr. Pallavi Kalwande.
So you are host Pallavi. So you can start sharing from there only, and you can control your presentation from there.
Okay, sir.
Okay, thank you.
Trinanjan, Dr. Trinanjan, meanwhile, if there are any questions in the chat box, please ready with those questions.
Yeah, sure.
Yeah.
Is my screen visible? Hello?
Yes, Pallavi.
Is it visible?
Yes, Pallavi.
Okay. Good morning, everyone. Myself, Dr. Pallavi. I am from MGMS Sevagram. Our study was about palliative radiotherapy to triage patients for radical treatment in locally advanced head and neck cancer during COVID crisis. As we know, during COVID pandemic, workload on government centers is increased, and because of that, alternate staff working, shifting staff for COVID has added to higher workload. And after 3 months of lockdown, large number of patients are presenting in locally advanced stage. And locally advanced head and neck cancers are known to have variable response to radiotherapy. A segregation of patients who will benefit from radical RT is in need of time to avoid in hospital crowding. In such a crisis time, patient triage is of utmost importance. And we know that 30 grain 10 fraction is known to be an effective palliative radiotherapy regime in advanced head and neck cancer. Basis on this, we have designed a study with primary objective of is the palliative radiotherapy regime effective? Hello? Am I audible?
Please don't stop. Continue speaking unless somebody tells you to.
Okay, ma'am. Okay.
It's palliative radiotherapy. Excuse me 1 minute, Pallavi. People who are not talking or participating just now, please mute yourselves. It's distracting the presenter. Pallavi, please continue.
Okay, ma'am. Our primary objective is the palliative radiotherapy regimen effective to select the patients for curative radiotherapy, and secondary objective was to assess for toxicity profile. This was our study design where we have selected 32 patients of stage 4A and 4B advanced squamous cell carcinoma, those who were upfront inoperable. All patients were subjected to palliative radiotherapy with 30 grain 10 fractions. After that, response assessment was done on day 11, day 18, day 25 and day 32. Those who had partial response and complete response were further received dose escalation of 36 grain 16 fraction, and those who had stable disease or progressive disease received palliative chemotherapy. All patients were followed up regularly at 1 month and 3 months. This is how the contouring was done for the primary radiotherapy of 30 grain 10 fraction. Looking at the patient characteristics, buccal mucosa was the most common diagnosis, and apart from that, stage 4A was the most common stage of presentations. Males were more as compared to females, that is 63% versus 38%. Looking at the results, 28% had stable disease, 59% had progressive partial response, 6% had progressive disease, and 6% had the complete response. Out of that, 68.7%, those who had partial response and complete response were further planned for 36 grain 16 fractions with 2 more cycles of weekly cisplatin. During those escalations, all 2 patients defaulted who did not complete the RT, but 20 patients who completed the RT had complete response, that is 100% 100% response at the end of treatment. On median follow-up was of 3 months, ranging from 1 to 6 months, and at the end of follow-up, no patient had disease progression. 100% local control was achieved at the end of 3 months. These are the images of few of the patients. One of the patients included in our study, which has a good response. On multivariate analysis, younger age of presentation, poorly differentiated histology, oral cavity as a primary site were significantly associated with better outcomes. Looking at the acute toxicities, skin reaction, grade 2 skin reaction was more common. Few patients, 10% patients had grade 3 skin reaction. None of the patient had grade 4 during radiotherapy. We're looking at the acute mucositis. Grade 2 mucositis was more common. Few patients had grade 3 and 10% patients experienced grade 4 acute mucositis. After follow-up, after completion of treatment on follow-up of the 1 month, grade 1 toxicity, grade 1 skin toxicity was more common with 87.5%, where none of the patient had grade 2 or grade 3 toxicity, whereas grade 2 mucositis was more common with 62.5%, and 37.5% had grade 3 mucositis, and no grade 4 mucositis was observed. Thus, we have concluded that 30 grain 10 fraction is the effective regime to select patients for radical radiotherapy, and good local control can be achieved in selected patients with dose escalation. But further randomized studies are needed on larger sample size to confirm the findings. Apart from that, our study has a limitations as it was a pilot study. It has a smaller sample size and shorter duration of follow-up. That's all. Thank you.
Yeah, thank you, Dr. Pallavi. So I don't think there are any questions in the chat box. Any questions on YouTube?
Yeah, there are 2 questions actually. Babusha sent me a WhatsApp chat. One was to Ravi that is there any outcome difference on those who could not complete the intended dose?
Hello.
Sir, in my cohort, all the patients had completed the intended RT dose.
Okay. And second was to you, I think, on what basis the contralateral nodals were included or excluded. So there's already a definite guideline for that though.
So, in our code, we have included the contralateral node in case of 1A positive or tongue or fluoromouth primary buccoalveolar complex disease with crossing the midline, who crossing the midline. That is there, sir.
So any other question from the audience?
The Sarin sir has asked about the inclusion criteria of the patient who did not complete the treatment after the inclusion. So I want to reply that we have included the patient who had completed the radiation therapy and with at least 1 follow-up.
Okay.
Can I ask one question?
Sure, ma'am, you can ask.
Time? Yeah, so what would her treatment plan have been in a non-COVID situation for these locally advanced? Would it have been any different, or is it the standard protocol in the hospital?
So, ma'am, whom are you asking?
For Dr. Pallavi.
Okay,
Dr. Pallavi.
okay.
So please respond, Dr. Pallavi.
Can you just repeat the question, ma'am?
I said, I understood that this was during the COVID time for a locally advanced disease. What is your normal protocol? Would you have, is this the standard protocol for even for non-COVID times, or has it been modified just for the COVID situation?
No, ma'am, it is just modified during COVID time. Generally, during non-COVID time, we used to follow the normal conventional radiotherapy.
Okay, there was one more in the chat box I received through the YouTube. Again to Ravi, that for non-tongue oral cavities, what are the criteria for taking contralateral nodes?
I think that has been answered, right?
Yes, ma'am. Yes, ma'am. Yes, ma'am. He answered actually. On those.
There was another question for Pallavi about what was the BED delivered, the total BED to these patients.
Total BED was 83 gray, ma'am, which was equivalent according to while if you are giving conventional fractionation with 70 gray in 35 fraction, it comes around 83 to 84 gray. It was equivalent to that.
Can I ask a follow-up question on this?
Yes, ma'am.
Yes, ma'am.
Pallavi, you have not given any gap, as I understand from the abstract, between your 30 gray in 10 and your 32 gray, right?
Ma'am, actually, we have given gap. We have assessed like from day 11, then day 18, then 25, and then 32. First, those who have response on day 11, either partial response, those were started directly on treatment. And
So
those
how will you account for the late effects of this treatment?
After completion of the treatment, will keep on following the
Pallavi, please
patient.
get my question. In those patients in whom you chose to treat 30 gray in 10 fractions, followed immediately by the 32 gray.
Okay.
How will you account for their late effects?
As high dose per fraction was given, we'll keep on following to look for the late reactions.
Pallavi, the reason I'm asking you this question is you need to understand two things. Sorry, if there are any other questions, we could discuss this when we give our expert comments. If there are any other questions, can you please go ahead?
Madam, I just have a question to Rabi. What guidelines were followed for contouring? Are there any guidelines or they were institutional guidelines? He talked about those.
Rabi, did you get the question?
Were those institutional guidelines or any international guidelines for post-operative contouring?
So can I answer on behalf of Ravi? Since
Nanjan, don't. I want Rabi to answer. Where is Rabi? See, because this symposium is meant for them. Anil, where is Rabi?
Yes, sir. Yes, sir.
Yes, please answer that question.
Sir, you asked about the indication of adjuvant RT?
No. Contouring guideline.
Whether you have used any standard guidelines. Are there any standard guidelines or the institutional guidelines?
So the nodal contouring were done as per the Gregor, sir.
Primary.
Hello.
Sir.
Yes.
Can you answer that question? Did you follow any guidelines for target delineation or were they institutional guidelines?
What should I do, sir? I didn't get.
Please mute yourself, other people.
How can I do that?
The post-op bed. Hello.
Yeah, Rabi, go ahead.
Please go ahead.
So the post-op blade will be contoured and
okay. So make a host. Okay.
Intentionally include the flap. That is, if it is going to the lower neck, then we have not included the flap, and we did not change the flap to the lower neck.
How did you contour the primary?
According as for the pre-op disease, ma'am. The extent of pre-op disease.
What did you do there?
We have to fuse the pre-op imaging with the planning CT.
Are there any published guidelines? Are there any published guidelines?
Ma'am, Gregor.
That's for node.
Are there any published guidelines for target delineation in the post-operative setting? मैम को मत बताओ, डॉक्टर गिरीश को बताओ.
I think, madam, you can cover that in expert comment.
So Dr. Girish, actually there are published guidelines. There's Edward Chu's guidelines. There's one Nancy Lee's guideline internationally. And more or less what we were doing in bony landmark base has been translated into the conformal ones. But yes, it varies from institute to institute, and especially international guidelines, the volumes are very small because they don't have tobacco infested patients more. I actually like Ravi's topic very much because in the same line, I have published our institutional data as abstract in Astro and writing the full paper. So all the best, Ravi. Do it very well.
Thank you, sir.
So in this context, I'll tell you what the incident, what Trinanjan said, those were actually the retrospective analysis of individual post-operative IMRTs that were carried out. Very recently, there is a set of guidelines that have been published from the group in Liverpool in oral oncology, and they kind of tell you the exact way to go about contouring in the post-operative setting. That's the recent one with Matthew Beasley.
Yeah,
so if the students in the audience can actually refer to that guideline. So we'll discuss this. Are there any more questions? Anil, how are we doing about time?
So now we are good at time.
Okay. So are there any more questions?
No, ma'am. There's no posted. None posted.
So then can we give our Vishesh Tippaniya?
Yes, ma'am, we have the expert comments.
Yeah, Nikhil, will you please go ahead?
Nikhil, please switch on your video every time you're.
No, we can see him, man. You can see him with the mask.
In all our meetings, he keeps it video off type. Nikhil.
Dr. Nikhil, we'd like to have some comments from you.
No, he's muted. We asked him to unmute.
Oh. No, he's not.
Nikhil, you're not audible.
You have to increase your volume, Nikhil.
But there is no audio.
So you are muted, Nikhil. Increase your volume.
Maybe you can try without the earphones, sir.
Yeah, am I audible now?
Yes.
Yeah, regarding the IMRT paper, it's a good data to have. The use of adjuvant IMRT is increasing. There are some institutions which are practicing the IMRT for all patients. So this type of data we need to compile, and we need to see what are the failure patterns, especially. Delineation in an adjuvant setting remains a challenge. Regarding the neck nodal delineation, especially if there is a pectoralis major flap reconstruction has been done, then there is a challenge to contour. How much flap to include? Should we go till the clavicle for all not negatives or not? That remains a challenge. Second challenge remains, controversy remains, is regarding the contralateral neck nodal irradiation in a buccal mucosa and the alveolar. So what I follow is I try to give a contralateral 1B and 2 irradiation for all node positive buccal mucosa and the GBS tumors. So that is the one thing. Second thing is regarding the toxicities with IMRT. Definitely there is an advantage when we treat with IMRT, both for the acute as well as the late toxicities, which has been shown in the analysis. So that is one for the first paper. Ma'am, if you want to add something for that.
Yeah, so I think Nikhil has addressed most of the issues. The other thing that I would like to especially talk to the audience about is coverage of the flap. Now, what we have done in our series is that, and this is different and controversial, is that we have not chased the flap. What we've done is especially when there is a free flap, we have not chased the flap. The flap is unintentionally a part of the target volume. In cases where there has been a heavy nodal burden with extracapsular extension and a flap like the pectoralis major flap has been used, in those cases, we have also covered the flap in the area where there was no disease in the preoperative setting, 250 gray in the neck, in the uninvolved area. The other issue about contralateral nodal volumes, we have tried to restrict our volumes to what we used to do with anterolateral fields in the conventional setting. So essentially where there has been a high nodal density with extranodal extension. In those patients with 1B and 2 disease, we have gone to the contralateral side, or for midline tumors, or for tongue, floor of mouth malignancies. For the others, we've actually just taken lateral volumes. This is at variance to what has been proposed by Vincent Gregor and from Clifford Chow's paper, but we have chosen to do this based on our own experience from the conventional setup, and we've not included contralateral nodes unless those above criteria have been followed. And the other thing, actually, as a part of the same exercise, we have chosen to do a propensity score matched analysis with a conventional cohort. We have not presented the results of that cohort here because it would be premature to say that actually IMRT scores as far as disease control is concerned, pending any level 1 evidence. So that is another part of the exercise which we will be continuing as we complete this thesis and the work related to it. Thank you.
Regarding the second paper for oropharyngeal cancer, it's a good data for a large number of patients, more than 600 patients. As expected, we are mostly dealing with the tobacco-related oropharyngeal cancers, where only we have around 10 to 12% positivity with the HPV positivity in the tumors. Outcome-wise, yes, as expected, very nicely presented good outcomes, long-term follow-up and the long-term outcomes. Second thing which we need to see is regarding the concurrent use of chemotherapy. More than 70% received the chemotherapy. That is also good with a good tolerance and the good outcomes. HPV remains the controversial topic as of now regarding, as mentioned by the Sheetal, whether to go for a de-escalation or not. So what current data and the guidelines says is no for any de-escalation in a clinical routine practice. Continue with standard treatment with a chemoradiation for a stage 3 and stage 4, and only radiation or a surgery for stage 1 and stage 2 tumors. So that remains the standard.
To add my 2 bits to this comments that Nikhil has already made, I would actually request Sheetal, this is very good work because it's a large volume from our setup, to look at the risk classification or the risk categorization among the HPV positive patients. I know it is difficult because the risk categorization in literature is based on back years of smoking, which we don't have, but you could at least look at what was the association between tobacco in these patients who are P16 positive. That's one thing. And also look, because if you remember Vedang's analysis,
yes, ma'am,
irrespective of the HPV status, it was tobacco that actually had the played the influencing role in the outcomes. So I think it is important for you to look at the tobacco status in these patients who were HPV positive. The other thing is that, did you make a note in the treatment about the brachytherapy that was used in any of these patients? That will also be important when you talk about treatments and oropharynx, because that's a part of your secondary objectives.
yes, ma'am.
And also the other thing is the overall survival is very high. If you look at the local regional control and the local controls, okay, in relation to that. So I would ask you to look at your follow-up data well, because sometimes these high overall survivals, most often the high overall survivals are a function of the follow-ups, okay? So please look at that also, because otherwise you would definitely have to draw reference to the fact that how many of these patients post radiotherapy could be effectively salvaged. Because simply a high overall survival means that post failure, there was effective salvage therapy that was available. So I think salvage should also be an important component of your reporting then, all right?
Yes,
otherwise it was a very good effort, because you have looked at almost screened 4,000 patients to know that they've undergone radiotherapy, coned down to 1,000 plus, and then finally coned down to 630. A lot of efforts, very good. But I think you should look at these parameters also, because then your work will be kind of complete. Yeah. Congratulations.
Regarding the third paper by Dr. Pallavi, the same issue which Dr. Sarvani already discussed regarding the how to manage the lead toxicity and what expectation what we will have with the lead toxicities when we give such kind of doses 30 gray for 10 fraction followed by 32 gray. So that remains the only concern. Otherwise, it's a good regimen for triaging three things. In a COVID area, yes, especially a good way to triage the patients. Those who are responding, escalate. Those who are not responding, just leave at 13 gray in 10 fraction and stop radiotherapy. So if Pallavi is there, ma'am, can we discuss?
Yes, sir.
Yeah. So Pallavi, in addition to what I have said before and what Nikhil has already said, since you're writing a thesis, I presume this is thesis work or is this just an additional project you are doing?
It was an additional project, ma'am.
Okay, fine. Even then, if you are going to publish this data, you made a comment early on in your introduction that there is increased load on the government setup in the COVID pandemic. If you are making this statement, I would suggest that you have some literature or some data to back this up, okay? Because otherwise it is just a statement based on impressions, all right? And
Yes,
in your
ma'am.
case, you must have had that impression because you are a center and there is nothing else around, no other centers around, right? So you may have, for the 100-kilometer radius, maybe there was nothing else around. So you may have had that impression. And the other very important issue is what we've already talked about, and that is the late effects. You have analyzed response every week, right? And
Yes,
then
ma'am.
the ones who you thought responded at the 30 gray in 10 fractions completion, you have chosen to escalate these patients. There is the issue of late effects because both your schedules are hypofractionated schedules with a large dose for fraction. Though in the 30 gray schedule, you have used smaller and more conservative volumes, in the 2.5 gray per fraction, you've used relatively higher volumes because you've gone on to do what you would have otherwise done in the radical setting. So this is an important thing that in those patients, I think 20 patients or so, or 20% of the patients in whom you've chosen to do that, please follow them up carefully because this is something that you will have to look at in due course. The other thing is that about assessing response weekly. And my question actually to you is that why did you choose 30 gray in 10 fractions? Why not 20 gray in 5 and or some other hypofractionated, more hypofractionated schedule? You must have heard of the quad shot, right? So why did you choose something like that or any kind of adaptive palliative regime?
For 20 grain 5 fraction, ma'am, dose per fraction was very high, like 4 gray per fraction. And after that, BD to total BD, I have to go up to 84 gray by 20 grain 5 fraction, and then dose escalation. The BD was not coming. BD is less as compared to the conventional. What we are giving is 1735. And in second, when we did dose escalation, that time we use conventional fractionation only, that is 2 gray per fraction to the larger volume. For only GTV volume and the smaller volume, we went for high dose per fraction, that was a 3 gray per fraction.
Yeah, that's right. But you have not given any gap. Of course, the gap would have obviated the outcome. But at the same time, not giving a gap and giving this quickly followed regime is a little bit of a concern when you're talking about late effects, okay? Because you've done most of your VD calculations for outcomes rather for the tumor,
yes,
right? So that is why you have to look at it. And the other thing is, did any of these patients receive concurrent therapy? I think the later half they did, right?
Yes, ma'am.
So that's another thing that you will have to look at in these patients. What happened to patients if they did 30 gray in 10, you've done 30 gray in 10, and after 2 weeks, which is the typical split course fractionation way of assessing response, if you found a favorable response, did you escalate in these patients?
Yes, ma'am. I escalated in those patients also, and those.
Can't hear you, Pallavi. Can't hear you.
Just a second. Am I audible now?
Yes, yes, yes.
Those who had response on day 10, just after finishing radiotherapy, those were escalated, and we waited for the rest of the patients to develop response. Like till 1 month we waited. Those who had response at the time, that time only we escalated those for them.
Okay, so you may have to keep, different cohorts and see what happens to them in the long term, maybe at 3 months, 6 months, a year or so, if they do survive, right?
Yes, ma'am.
Yeah. Thank you. That's
Thank you, ma'am.
not for me.
Thank you.
If there are no other questions or comments, we would move on to the next session.
Yeah, thank you. And it was a great presentations for all the speakers and a great summary by both the experts. Thank you for calling us, me and Dr. Prinanjan as
Yep.
chairpersons.
Thank you. Thank you, everyone.
Best of luck for the next session.
Thank you.
Thank you.
Thank you, ma'am. We would now like to begin the neuro-oncology session. I would like, Dr. Bhushan Zade would not be able to make it considering he's traveling. So I would like to invite Dr. Vandana Jain to chair the session. Ma'am is a professor and head department of radiation. Ma'am is a professor and head department radiation oncology in Rural Medical College, Pravara Institute of Medical Sciences in Loni. Ma'am, could you unmute yourself?
Yeah, good morning. Good morning all. Can you hear me? I think you have
Please log in, log out of 2 devices. Log into only one device. Otherwise, the voice will continue to echo.
Dr. Vandana?
Hello.
We can hear you now.
Now you can hear me?
Yes, ma'am. There's an echo, ma'am. Are you logged in through 2 devices?
No, actually nearby one resident is sitting. She will. No.
Ask her to move to the next room, ma'am.
Okay. Or I will move to the next room.
Hello, can you hear me? Dr. Zade here.
Oh, yes, yes. Dr. Bhushan is also here. Sir, would you be...
No, the problem is I'm here, but I'm traveling. That's why I won't be able to come.
Yes, sir. Yes, sir. We are aware of that.
So please take care of from my side also. Dr. Jain, please.
Yes, yes. Hello. Yeah, now I think you can see me also.
Yes, yes, we can see.
So it's just Dr. Bhushan, then I will be announcing for all.
Yes, ma'am.
Okay. So first of all, I would like to thank all the organizing committee members, Dr. Vyas, Dr. Sonali Pingle and Dr. Anil for giving me this opportunity for today chairing this session on neuro-oncology. There are 2 presentations. Both the presentations, they are mainly very good, but I think with the diagnostics and a lot of new things which will be coming up. And so first I would like to invite the first presentation by Dr. N. Christy Sanju. He will be presenting on medulloblastoma radiomics as a molecular adjunct in diagnosis. So Dr. Ann Christie, please.
It was on.
Good morning, everyone. Today I'll be presenting my study titled Medulloblastoma Radiomics as a molecular adjunct in diagnosis. Medulloblastoma is the most common pediatric malignancy of CNS. Evolving literature suggests the use of a risk stratification system based on the consensus molecular subgroups of medulloblastoma, namely WNT, SHH, Group 3 and Group 4, has a better prognostic model as well as a basis for future personalized therapy.
You have to share your screen.
It is shared now.
No, to the presentation.
Share.
So can you see now?
Now go to the thing.
Is my screen seen now?
Yes, it is visible now.
I'll start again. Good morning, everyone. Today I'll be presenting my study titled Medulloblastoma Radiomics as a Molecular Adjunct in Diagnosis. Medulloblastoma is the most common pediatric malignant neoplasm of CNS. Evolving literature suggests the use of a risk stratification system based on the consensus molecular subgroups, namely the WNT, SHH, Group 3 and Group 4 medulloblastomas, as a basis, as a better prognostic model as well as a basis for future personalized therapies. But its use in routine clinical practice is limited by need of infrastructure, expertise, and cost, and therefore it's not available in all the centers of the world. Imaging-based classification of medulloblastoma, though in its infancy, is an interesting area in which is evolving towards translational research. Before introducing the radiomics studies in medulloblastoma, in brief, radiomics is the use of qualitative and quantitative imaging features to create a data space from which you can analyze and subsequently use it in clinical practice. So that there are two major modeling methods of radiomics studies. One is the feature-based radiomics and other is the featureless radiomics. So feature-based radiomics most commonly or conventional radiomics involves semantic and texture features. An institutional study done in 2018 used 19 semantic features and a nomogram-based model to predict the 4 molecular subgroups of medulloblastoma. Eve et al. In 2019 used a more objective texture analysis methodology with the support vector machine classifier. Both these studies resulted in a good prediction of SSH subgroup and group 4 medulloblastomas, but it was suboptimal with WNT with the best prognosis and group 3 with the worst prognosis. 2 more studies were published this year after the conceptualization of our study. Chen et al. Used featureless radiomics and conventional neural networks, which resulted in good predictive ability for all the 4 molecular subgroups. And Yan et al. Incorporated clinical, semantic, and texture features and a random forest classifier, but it led to suboptimal prediction of group 3 and group 4 medulloblastomas. So the objective of our study was to distinguish the broad molecular consensus subgroups of medulloblastoma using MR texture analysis on T1 contrast and T2 MR images. This was a retrospective observational study with time frame being January 2007 to December 2019. All histologically confirmed medulloblastoma patients whose molecular subgrouping were available and pre-treatment axial T1 contrast and T2 images available in DICOM format were included in the study. And when molecular subgrouping was not available or inconclusive or equivocal, they were excluded from the study. So the axial T1 contrast or T2 images acquired were transferred into a proprietary texture analysis software, TextRat, and manual segmentation was done on each slice and verified by an experienced neuroradiation oncologist. Since our sample size was only 38, we used a data augmentation methodology known as single slice multiple sampling approach, which is described in prior literature. And this resulted in 174 T1 contrast and 170 T2 contrast labeled augmented data. TextRad uses a pre-processing using a Laplacian of Gaussian filter, which reduces noise and enhances edges, and also uses filters of various size to provide fine, medium, and coarse texture features. A total of 82 texture features were extracted, each from T1 contrast and T2 weighted images, which included first order texture features, second order topographic and shape features. First order gives only the gray level intensity distribution, whereas second order also talks about the spatial interrelationship between these gray level pixels. We use gray level co-occurrence matrices, which were 1 pixel and 4 pixel apart to look at fine and coarse texture features. To remove non-important features and reduce the dimensionality, we used a feature selection method using lasso regression, and the lasso selected features were included in the final model, which was done using SVM. So support vector mission, the concept is basically to find a hyperplane between the data sets. And if it is a non-linear data, it converts the input data into a higher dimension using a kernel function to find the optimal hyperplane which can divide the data. And the models were evaluated using area under receiver operating curve. So we use a combination of multiple SVM selected features to arrive at the best model, and these are the results of the best model. The best model was arrived at using 30 GLCM and 6 shape features from T1 contrast MR images. We used a cubic support vector mission classifier with 10-fold cross-validation strategy, and the overall predictive accuracy was 80.5% with AUC of 0.93 for WINT Group 3 and Group 4 and AUC of 0.90 for SHH. The sensitivity was 73%, 70%, 86% and 82% respectively for WINT, SHH, Group 3 and Group 4 medulloblastomas. The current study performed reasonably well compared to its predecessors. So in conclusion, radiomic analysis of MR images in medulloblastoma predicted the molecular subgroups with reasonable degree of accuracy, but this strategy needs further evaluation on an external data set for its use in clinical management. This is a rapid and cost-effective tool which could be incorporated into routine clinical practice. It could help surgeons safely decide between the extent of surgery versus morbidity. Also help towards optimization of adjuvant radiotherapy and chemotherapy with an intent to maximize cure and reduce late sequelae. Thank you.
Okay, then I think questions will be taken later on. So I will invite the second speaker, Dr. Prithvijit Moitra. He will be presenting on correlation of 06-methyl guanine DNA methyl alkyl transferase gene polymorphism with hematological toxicity of temozolomide in adult diffuse glioma. So, Dr. Prithvijit Moitra.
Yes. Good morning, everyone. I am Dr. Prithvijit Moitra, junior resident at Tata Memorial Hospital in Radiation Oncology Department, and I will be presenting these initial reports of this study, which is correlational study of MGMT gene polymorphism with hematological toxicity of temozolomide in adult diffuse glioma. So as we all know that MGMT enzyme is actually a de-alkylator or demethylator of O6 position of guanine in the DNA, which is produced due to chemotherapeutic drugs or environmental alkylator. And the gene that produces this MGMT enzyme, which is a large gene, which is located in the chromosome number 10, long arm of chromosome number 10, has a multiple regions of interest, which molecular changes of which regions may causes some functional alteration or the expression alteration of the gene as well as of enzyme. So among all these regions of interest, the most established region is that promoter region of the gene, which is a CPG island. Hypermethylation of this promoter region has an established role in glioblastoma management, as we all know. So likewise, there are multiple single nucleotide polymorphic regions present throughout the MGMT gene. Among them, the most well-researched and are these L84F, 143V, and K178R. These three regions are actually well-researched due to its critical location, like L84F is located near the zinc binding site. Zinc is the metalloprotein for this metal for the activity of this enzyme, as well as the location of I143V, which is located near the active site. So it was thought that any changes in the polymorphism, due to the polymorphism, there might be any changes at the molecular level that may affect the enzyme functionality. So there are multiple studies done in vitro or in vivo that were researched to look into this matter, but the results are very contradicting. Some studies showed that the presence of the polymorphism in this region decreases the expression. Some studies show that increases the expression of the enzyme, and some are so that the data are very contradicting. So the L84F, so for this case, the wild allele is C and variant allele is T. For I143V and K178R, the wild allele is A and the variant one is G. So in the 2009, on study published by Armstrong et al. So it was done in Caucasian population that showed that this presence of G allele in these two region, 143rd and 178th region, have a higher chance of higher risk for developing temozolomide induced toxicity, high grade hematological toxicity in glioma patients. So my study is based upon that study. So my objective of this study is demonstrate the correlation or lack of correlation between the severe hematological toxicity and three common MGMT SNPs, L84F, 143V and K178R in adult Indian patients with diffuse glioma treated with temozolomide. So the inclusion criteria was age over 18 years at the time of index diagnosis, newly diagnosed diffuse glioma patient being treated or previously treated with RT and temozolomide who developed or have developed significant hematological toxicity and temozolomide stopped temporarily or permanently due to the toxicity. So the significant hematological toxicity that means here is grade 2 to 4 thrombocytopenia or grade 3 to 4 neutropenia, for which we stop temozolomide temporarily or permanently, and the written informed consent was the must. So the exclusion criteria were recurrent or progressive glioma treated with salvage systemic therapy and patient developed toxicity in the salvage setting. So these were the excluded criteria, and the patient with previous history of severe myelosuppression due to other cause, they are excluded also. So methodology was after accrual, 6 ml of peripheral blood collected from the cases, and the genomic DNA was extracted from the whole blood in Dr. Sarin's lab. PCR were run using lab designed 2 different forward and reverse DNA primers for L84F and 143V and K178R respectively. These forward and reverse DNA primers were designed in our lab only. Quantified PCR products were run for the Sanger's gene sequencing. Chromatograms were analyzed for wild, hetero, and homozygous products for each SNPs. And after that, the data regarding the grades, duration of the toxicity, grades of the toxicity, and the toxicity developing in the adjuvant phase or concurrent phase, types of hematological toxicity and demographic characteristics were analyzed, or correlational analysis were run using Fisher's test and chi-square test. So from May 2020 to September end 2020, we screened 35 patients, and out of which 33 patients were included in this study. So what we found out, among the 30, we could run the 30 for the L84F for all 33 patients, and we found out that the CC, that is the wild expression, is present in 51.5% of our study population among the 33. TC, that is heterozygous, it is present in 42.5%, and TT, that is the homozygous variant, this is the variant, and it is present in 6.1% of the study population. So the expression of C among the whole study population is 71.3%, and expression of the T allele, including both heterozygous and homozygous, total expression of T allele is 28.7%. We could run out of 33 only for 32 patients for I143V and K178R. So for one among the one patient, the study result was equivocal. So we have taken 32 patients report. So here we found out that 81.8 patients the allele is the expression is wild, and 12.1% the expression were heterozygous, and in 3.1% patients the expression were homozygous. So 90.7% patients in our study population expressed A allele, which is the wild, and 9.3% patient expresses the G allele, which is variant. So this is the chromatogram. So here you can see this, here the green peak represents the A, and here a single peak is present. So this is wild. Here the single black peak, which is the G. So it is a homozygous, and this is the both peaks are present simultaneously. So this is the heterozygous variant. Similarly, L84F, this is the wild, the blue one is T, and blue one is C, and homozygous, the red one is T, and there is both peaks are present. This is the heterozygous. So another thing was found out that I143V and K178R are present simultaneously. That means if one allele is present, that is heterozygous, that is G allele. Simultaneously the same allele was expressed in K178R. So this is called linkage disequilibrium. This is established in the previous studies also. So I have taken I143V and K178R simultaneously. So what were the result and conclusion? So out 72.7% patient in our study, 33 patients developed grade 3-4 hematological toxicity during treatment. Grade 3 and 4 thrombocytopenia were significantly higher, than the grade 3-4 neutropenia in the both phase, both concurrent phase and in adjuvant phase. 18.2% patient took more than 2 months time to recover from the toxicity after temozolomide stoppage. Female gender were developed more grade 3, grade 4 hematological toxicity with significant, there is a significant correlation and p-value is less than 0.005. This data is well established in various previous studies by clinical audit from our hospital and studies by Armstrong et al. And other studies that female gender has a significant predilection to develop hematological toxicity than the male gender. Age 37 years or less has a significant, we found out that a significant correlation with grade 3-4 neutropenia or both toxicity developing simultaneously in adjuvant setting with a p-value of 0.03. 81.2% of 16 patients who are heterozygous or homozygous for L84F and 80% of the 5 patients who are heterozygous or homozygous for I143V developed grade 3-4 toxicity. So there was no significant correlation established with L84F and I143V K178R and the grades of toxicity in any phase. But we found out that there is a significant positive correlation established between the I143V K178R and the duration of persistent toxicity of more than 2 months.
Can someone who's speaking mute themselves? Miss.
Hello.
Dr. Ashok Singh, can you please mute yourself? Can you please mute yourself, Dr. Ashok?
Could you please mute yourself?
So the SWOT analysis for my study was the strength. It is the first of its kind in non-Caucasian population. All previous studies were done in Caucasian population only or Chinese or Japanese population, but this is the first of its kind study specifically which is done in Indian population. There is a significantly high T allele expression, higher than the reported in world data in general population. I have taken the general population data from the 1000 Genomic Project database, where it is shown the expression of the T allele in South Asian population. The South Asian population is 15%, and the highest reported T allele expression in Central American or South American population, in Peruvian and Mexican population, it was 27%. In our study population, it is 28.3%. So it is higher than the highest reported in the general population. So this is one interesting finding which is present in the study. And another important thing that we did not find out any correlation with the grade, but we did found out that G allele has a positive correlation with the duration of the toxicity, which was not mentioned with a single retrospective study by Armstrong. So this is the novel finding. And the weakness of the study is it is a small sample size. We were predicting to get 40 sample size till our study duration, but we could get only 33 patients, and the cases were only taken. We did not include the control, those who developed, those who did not develop any toxicity and were on temozolomide therapy. The opportunities is that it is encouraging result in the cases needs further validation in large case control study. And the threat or the problem with this study is that variation of expression is different demographics. So among the South Asian population, the expression of this T allele or G allele is significantly different between the Bengali population or Gujarati population or Telugu or Tamilian population. Number two is unpredictable phenotypic expression. So various studies, some study find out that there is a relation, positive correlation with the toxicity, a positive correlation with the genetic gene functionality, and some study did not find out any functionality abnormality, and some study found out that presence of polymorphism would actually increases the effect of MGMT. And the last common problem is the missing one of new unknown SNP that we don't know, maybe affecting simultaneously to develop other toxicities and grade 3, grade 4 hematological toxicity while restricting the toxicity to grade 3, grade 4. Thank you.
So I think both the presentations are over.
Yes, ma'am. We'd like to invite the experts. Would you invite?
Yes, Dr. Dev Narayan Datta and Dr. Tejpal Gupta. Both of them, if they can join for the expert comments. I invite Dr. Dev Narayan Datta.
Sir?
Yes.
Yeah. Dr. Tejpal is there?
Yeah, I'm there, Dev Narayan. Maybe first the questions. I think there are some questions on the chat box. Let the speakers answer those questions. Then we can, and you can give your comments.
Yes. See,
there was a question for Christy, so would you like to ask that?
Yes, so I think Christy, are you there? So I think Riddhi Jyoti wants to know how would your pre-operative identification on imaging regarding the molecular subgrouping, how does it impact the neurosurgeon's extent of resection? I think that's a valid question.
So even though in medulloblastoma, the standard of care is maximal safe resection, in the molecular era, there has been a study by Thompson et al. Which shows that only in group 4 medulloblastomas, gross total resection or near total resection has a PFS benefit when compared to subtotal resection. Also because most of the medulloblastomas are near brainstem and postoperative neurological morbidity is a big concern, including intellectual morbidities and language deficits. So if there is a small residual tumor which is stuck to the brainstem and if you would predict a large postoperative neurological morbidity, then maybe we could, based on molecular subgroup, we could consider having a safe resection rather than a rigorous resection.
But Christy, that would be regardless of the molecular subgroup. I mean, the paradigm in neurosurgical, neuro-oncologic surgery is safe. I mean, you have to maximally resect within the confines of safety. So most neurosurgeons would do a maximal safe resection, and regardless, even if they knew what the molecular subgrouping was. So I don't think anybody would resect to precipitate deficit. But yes, if you know that it is a Wnt pathway medulloblastoma, maybe you would do a conservative resection as opposed to say a group 4 resection. But most neurosurgeons don't agree with this kind of a thing. They say that our job is to do a maximal safe resection and not precipitate deficit. So whether you tell us whether it is Wnt or group 4, group 3 or SHH, we would do a maximal safe resection. Are there any other questions from the audience?
There are no questions in the chat box, sir.
Yeah, so maybe Dev Narayan can start his analysis and comments on the.
In this, is it going to change? Means, do you not need to do any molecular study, and only the radionomics will help us to define the.
Sir, could you be louder? We can't hear you.
At any point when the molecular radionomics will be more defined, is it that sometimes it is going to replace completely the molecular evaluations for the molecular typing? So is it possible to do something like that in future?
So right now, this we are feeding the, like, it is a machine learning process. We are feeding the computer, saying we are telling the computer that, see, this is the molecular subgroups and this is the images. So please learn that this image means this molecular subgroup. For the computer to really learn it, we'll have to supply it with millions of images. The more data we provide it with, the better it learns. And maybe if to provide this millions of images, individual institution study is not enough. We would want to create a image database, a worldwide database, so that the computer learns more and more. So maybe in future, if that common image database is possible, then maybe this would
So,
create an
Dr.
impact.
Do you agree with that? That at some point of time that molecular assessment is going to go and only the radionomics will stay for defining this grouping type?
I don't think it's going to happen in my lifetime. I don't know, it might happen in Christie's lifetime. So I think the gold standard is going to be the molecular profiling, but increasingly with newer advances in imaging and more deep learning and machine learning and convoluted neural networks, I think the robustness of radiomics and radiogenomics has certainly increased over the years, but we have to bear in mind that there are so many challenges associated with these radiomics and radiogenomics studies, and the first generation of studies did not look at the quality of these criteria, and more recently there is a scoring system and there is a method of reporting these radiomic studies, and all radiomic studies are expected to follow those reporting guidelines so that there is some consistency in reporting of results. But I think we are a long way from replacing histology and molecular diagnosis just with images.
That now the MRI is important, right? So the 5.5 Tesla, 1.5 Tesla, 3 Tesla MRI. Is it going to have some implications in trying to find out more accuracy?
So there have been studies which have shown that different difference in MRI parameters can affect radiomic features, but our goal should be to identify those features which are stable in all these MR machines. That is, those features which is stable for 3 Tesla or 1.5 Tesla. Only select those features for the final model making, so that it can be widely applicable, because you can't unify the strengths of MR missions all over the world.
So Devnarayan, I don't think now, I mean 1.5, I mean nobody uses 0.5 Tesla now for diagnostic imaging. I mean it's either 1.5 or 3 Tesla. And that's why it is important that image acquisition parameters are standardized across MRI scanners. And of course, certain sequences would have different sort of results if you use a 1.5 versus a 3 Tesla MRI, and probably in the future even higher Tesla MRI. And there are certain sequences that are not so much sort of affected by the magnet strength. And once you sort of standardized the acquisition parameters and the extraction of features, I think the difference becomes quite insignificant.
Now, this is it more that SSH is better picked up with this radionomics, and group 3, group 4 is not that well picked up, or it is same for all for picking up all? The sensitivity and specificity is more with SSH or group 3, group 4, which is actually more important to pick up. That has some.
So I don't know. I mean, Christie showed that the area under the curve was almost similar for all of them, which is a very good sort of finding. Although previously, when we looked at semantic features, we could identify SHH and group 4 with reasonable accuracy, but WINT and group 3, and that was the same experience of the other group which used texture features. SHH probably is easier to diagnose, so is group 4, but group 3 and WINT, I think there is, you would struggle a bit. But if the recent radiomic analysis by Christie shows that it has excellent correlation with group 3 and WINT also, I think it's a welcome step. The only thing I would caution is that these are limited number of patients. So I think more data set needs to be analyzed, and of course needs to be validated in an external validation cohort. I mean, then only you could say that the area under curve of 0.9, if we maintain that area under curve of 0.9 and an independent validation cohort, then I think this is excellent.
Any more questions from anyone?
There's a question for Prithvijit in the YouTube live, sir. It says,
Now we come to Prithvi. Yeah.
this is Dr. Atharv asking, do you think CTC studies can help in days to come?
CTC studies. Does he mean circulating tumor cells? I mean, I don't know what he means.
For I think for glioma, I don't know the circulating tumor cell is there any role, but what I did here is I have checked the whole. I have taken the whole genome from the peripheral blood to find out the toxicity. It is effects on the bone marrow, then effects of temozolomide on the bone marrow. Probably in future, if we do this on from the tumor samples or tumor specimen, that will help in future to assess or to predict what's relation of this MGMT polymorphism with the survival or with the response to temozolomide, etc. But from in this study, I have taken from whole blood to assess the effect on the bone marrow by temozolomide drug.
So, Prithvi, I think that is not what he wants to understand. I think what he wants to know is whether there is any role of circulating tumor cells. And the simple answer to that question is that currently there is no such evidence to support the use of CTCs in adult diffuse glioma. However, liquid biopsies are like in non-small cell lung cancer and some other solid tumors, liquid biopsies are becoming increasingly popular in different types of brain tumors, including gliomas. In brain tumors, probably CSF is a much more rich and reliable source of tumor cells than the peripheral blood. And currently, I don't think anybody can suggest or say with some conviction that CTCs in blood can be a predictive or prognostic biomarker in gliomas. Devnarayan, you have any comments on that question? That
now, Prithvi, see now you have done on blood, right? So it is a somatic cell. So, but we expect the mutations in the tumor cells, right? So it may not be same. So the MGMT methylation status in the tumor cells and the blood may not be same. What is your comment on that, sir? You also can we interpolate that whatever in the blood will be in the tumor cell also, or it will be different?
I think because it is not possible to say, because there is one study which is published in China by Wang et al., where they showed that presence of L84F mutation, L84F SNPs has a poor prognosis. It is a poor prognostic factor with lower median voice. So that means that presence of this polymorphism is actually increasing the effect of increasing the expressions of MGMT, and its effect of temozolomide is reducing. So this is the contradicting what is published by Armstrong et al., where it is just the opposite. Presence of SNPs in MGMT actually reducing the effect of temozolomide and increasing the effect of temozolomide. So it is not possible to say from this to take the samples from the blood and to take the samples from the tumor that both will affect similarly, both will respond similarly.
So what you think? Is it going to be same, or most likely it will be different?
So Devnarayan, all gene polymorphism studies actually look at peripheral blood only. I mean, peripheral blood mononuclear cells, and it is assumed that any polymorphism that is seen in any of the peripheral blood mononuclear cells is likely to be the same in the tumor cells. But we haven't looked at that, and as Prithvi said, I mean, there isn't any significant such data published. Yeah. The Chinese did do a study where they actually showed that those who have that polymorphism actually do worse in terms of overall survival. So I think this gene polymorphism and response to treatment and gene polymorphism and prognostic implications, I think this is a very big area of research interest, and only once you dig deep into it, you will come out with some answers. We don't really know the answer. The question that you have asked, I really don't know the answer to that question.
See, now there are 3 SNPs you have seen, right? So do you see there are overlap there? All the 3s are in one patient, or have you seen like that? Or there are different SNPs in different patients? Is
No,
it that
no.
some patients have more than one SNPs in the MGMT methylation?
In my study, 3 patients actually among the 33 were present both SNPs. The SNPs present means one patient is LAT4 is heterozygous, but other 2 are homozygous. And another patient, the number of these patients are very few. In most of the patient, only one SNPs were present, either LAT4F or I143V or K178R. But this I143V, K178 are present simultaneously due to linkage disequilibrium. But in 3 patients among the 33, where they expresses all the 3 SNPs. And for them also the toxicity were poor, it is grade 3, grade 4, and both of them have months developed the toxicity, persistent toxicity for more than 2 months. So
that's very interesting.
So it is there in previous small case reports also. They have also showed that these 3 SNPs can present simultaneously, and it probably would have higher implication in development of the toxicity. But I don't know right now. It is not possible.
So occasionally you can get multiple of these SNPs, and I think the one of the biggest limitation of the work that Prithvijit has shown is that we have taken only cases, those who had developed significant myelosuppression, and we don't have controls. So patients who are on temozolomide and did not develop significant myelosuppression, those patients are not there in this. So the ideal design is a case control study, and once he finishes off with his thesis, I think that's the next step, that we embark on a case control design and try to see what is the status in patients who developed, who took temozolomide but did not develop any such toxicity. What was the MGMT gene polymorphisms
have
in
not
those?
developed? You do SNP for those patients also, then you can actually have around 15%, right? Wild type, the homozygous type.
Yes.
And how much is in
So unless you do a case control design, you can't really say whether any of these are actually associated or correlated with significant increase in toxicity.
So with the SNPs does not always mean that it will be expressive. No? It can be SNP, but it may not be active. No? It may not have any implications in mRNA generation. That is so. So the case control is critical to have it. Anything more from your side?
So back to the organizers, I think we are doing good on time, and we can have an extended break rather than a short break. Anil, back to you.
There was one more question in the chat box on YouTube. Is there any role of CTC in medulloblastoma?
The answer remains the same. As I said, circulating tumor cells currently in CNS tumors are not a sort of a big thing, unlike some other solid tumors such as breast and non-small cell lung cancer. And as far as medulloblastoma is concerned, I think there may be more of a role of trying to see these CTCs in the CSF rather than in the peripheral blood. So currently there isn't any role of monitoring circulating tumor cells either in gliomas or in medulloblastomas in CSF or in blood, but unless some studies are done which look at this aspect. So a baseline, what was the CTC level following treatment, whether it became undetectable, and whether it is going to before clinical evidence of recurrence, whether you can pick up the recurrence based on circulating tumor cells in the CSF or blood. I think those are interesting areas of research. Currently, there is no such role of monitoring disease in brain tumors, including gliomas and medulloblastomas, based on circulating tumor cells in either the peripheral blood or the CSF.
Thank you, sir. I would like to thank Dr. Vandana for chairing the session and the experts for their comments. I would like
thank you from my side also, and I thank both the expert speakers Dr. Devnarayan Datta and Dr. Tejpal for their expert comments, and both the presenters, because this is something new on diagnostics. This is radio diagnostics and genetics, which will be helping in the treatment, toxicities, and the patient outcome. So I once again thank all the organizers. So back to the organizers. Thank you.
Thank you, ma'am. I would now like to conclude the session and invite Dr. Anish to take over about the poster game.
Thank you, Babusha. So I would like to thank each and every person who had attended the session and given their comments, chats, and also every chairperson in head neck oncology, neuro-oncology, the expert speakers in both the sessions, Dr. Girish Batre, Dr. Trinanjan Basu, Dr. Nikhil Kalyani, Dr. Sarbani Ghosh-Laskar, Dr. Bhushan Zade, Dr. Vandana Jain, Dr. Devnarayan Datta, and Dr. Tejpal Gupta. So now we have a tea break, which will be for about 20 minutes. We will resume our session in breast oncology at about 11:10 to 11:15 a.m. In the meanwhile, we'll be displaying the e-posters. We have received a total of 5 e-posters, and 2 out of those best e-posters will be presented tomorrow in an oral presentation in the like noon session. So the 5 posters we have got is first is from Dr. Meenakshi Ravichandran on recurrent multifocal primary high-grade glial tumors in a young adult, a diagnostic and therapeutic challenge. The next is by Dr. Rupa Balachandran from Government Cancer Hospital, Aurangabad, on presentation of Guillain-Barré syndrome as paraneoplastic syndrome in cancer patients, a diagnostic dilemma. The third one is by Dr. Arpita Gite from Government Cancer Hospital, Aurangabad, on synchronous occurrence of carcinoma lung and intrahepatic cholangiocarcinoma. The next one by Dr. Megha Mahavar. She's from Loni. She will be presenting on carcinoma cervix with isolated metastasis in paraspinal region, case report at Rural Cancer Center, Loni, Maharashtra. And the last one by Dr. Purnima Kale, a rare occurrence of seminoma of testis in a treated case of cervical astrocytoma. So each poster will be displayed for a time of 3 minutes. And if there are any comments or any questions which has to be asked, that can be put in the YouTube link or on the Zoom chat. So I'll be displaying the first poster. So this is just a virtual tea break. I would like to request everyone to kindly go through the e-posters which will be displayed now.
बीच में वो गायब हो गया था।
अच्छा ठीक है,
कोई इशू नहीं होना चाहिए, मुझे लग रहा है टेक्निकल इशू होना चाहिए।
तो इस पे कर लो।
2007 से प्रिंट कर दी तूने रिपोर्ट इस पे।
Here with attached all reports.
मैंने टीपीएस वाले सिस्टम पे भी खोला है, उसमें करूंगा टीपीएस वाले सिस्टम।
हाँ अगर उसमें है क्या, इसमें है नहीं, इसमें कैमरा नहीं है, कैमरा वाला लगेगा।
कारण आवाज येईल अजून काय नाही.
we are done with display of all the e-posters. Two of these best posters will be selected for tomorrow's oral presentation. Now I would request Dr. Prachi Sawant to take over the proceedings for the next session, which will be on breast oncology from 11:15 a.m. to 12 p.m. and thoracic oncology from 12 to 12:45. Thank you.
Good morning, everyone. We'll now start the breast oncology session. I would like to invite the chairpersons for this session. I would like to invite the first chairperson for the session, Professor Sharmila Agrawal. Madam is a head of department and senior consultant in the Department of Radiation Oncology in Jaslok Hospital. And I would like to invite the second chairperson, Dr. Vijay Palve, head consultant, Department of Radiation Oncology, HCG Manavta Cancer Center, Nashik. He is also a TMH alumni. I would like the chairpersons to invite the expert commenters as well.
Yeah, good morning. Very well organized, Anil. Congratulations for this great endeavor. I will like to invite our first speaker who will be going to present. She's Nanki Bakshi, and she has she's from Pravara Institute of Medical Sciences, and she will be presenting her work on dose difference in target volume and organoid risk, and in left breast carcinoma post mastectomy, the difference between 3D CRT and IMRT.
I would like Dr. Nanki Bakshi to start sharing her slide, please.
Good morning, everyone. Just 1 minute. There's some problem with my internet connection. Sorry.
In the meantime, I also like to invite our expert team for this session, Dr. Bhavini Desaria and Dr. Rima Pathak from TMH to join us for this expert for the expert comments.
Sorry for the delay, everyone. Good morning. My topic today is dose difference to target volume and organs at risk with three-dimensional conformal radiation therapy versus intensity modulated radiation therapy in carcinoma left breast post-mastectomy patients, a study from a rural cancer center in Maharashtra. Breast cancer is the most common site-specific cancer in women and is the leading cause of death from cancer for women aged 40 to 44 years. It accounts for 33% of all female cancers and is responsible for 20% of cancer-related deaths in India. According to Globocan 2018, both sexes combined, breast cancer is the most commonly observed cancer and is the leading cause of death in women. Radiation therapy has a central role in the management of breast cancer after either breast conservation surgery or mastectomy, with attendant improvements in local control and survival. However, apart from the beneficial effects, irradiation may cause detrimental side effects in normal tissue. Specifically, when irradiating left-sided breast cancer, not only the lungs and the contralateral breast, but also the heart with coronary vessels may receive significant dose of ionizing radiation. Recent data from literature indicated that cardiac dose was associated with an increased rate of coronary events and cardiac mortality. To minimize dose to organs at risk as low as possible, new techniques have been developed which attempt to achieve this aim by increasing homogeneity and conformity of the radiation and better saving the risk organs. A number of studies have demonstrated dosimetric benefit of IMRT compared to 3D CRT for the whole breast in early breast cancer patients. But for post-mastectomy chest wall irradiation, such data is scarce. In case of chest wall irradiation, lung and heart remain the two most important vital organs, irradiation of which always causes a concern to the radiation oncologist. In this study, we evaluated the dosimetry in post-MRM patients of carcinoma left breast undergoing post-mastectomy radiotherapy using IMRT versus conventional 3D CRT. The aim was to study the dose difference to organs at risk with 3D CRT versus IMRT in carcinoma left breast post-mastectomy patients. And the objectives were to study the feasibility of IMRT in post-MRM patients and to compare the dose volume of the target, left lung and heart in patients treated with IMRT versus 3D CRT. It was a descriptive longitudinal study. All the 40 patients included in the study were planned for adjuvant radiotherapy to the chest wall with inclusion of the mastectomy scar and supraclavicular region. All patients were immobilized while free breath holding using a thermoplastic mold in supine position over a breastboard on the couch with left arm extended above their head onto armrest, abducted and externally rotated. Marker CT scan with contiguous 2 mm slice thickness was taken once optimal patient position was confirmed on Siemens CT scan machine. The chest wall, axilla, supraclavicular region, and organs at risk were contoured according to the RTOG guidelines for breast cancer. The 3D CRT and IMRT plans were generated using Eclipse 11.03 treatment planning software. And all the treatments were delivered with 6 MV photon using variant DPX linear accelerator. The total dose planned for every patient was 50 gray in 25 fractions to the PTV with 2 gray per fraction, 1 fraction per day for 5 days per week. The dosimetric assessment of both IMRT and 3D CRT plans were done for all 40 patients. The PTV parameters which were considered were D max, which was dosed to 2% of the volume, D minimum dosed to 98% of the volume, D mean and volume receiving 95 and 110% of the prescribed dose, homogeneity index and conformity index. Dosimetry for organs at risk. The mean doses of lung and heart, percentage volume of ipsilateral lung and heart receiving 5, 10, 20 and 30 gray were extracted from the dose volume histograms and compared. The first figure showing a DVH showing dose to heart, left lung and PTB in a 3D CRT plan, and the second figure shows the DVH in an IMRT plan. In the results, we observed that the PTB parameters were comparable in both the groups, but the HI index in the IMRT of value 0.13 showed a significant edge over the HI in 3D CRT of value 0.17. Similarly, the CI index in IMRT of value 0.96 was significantly improved compared to 0.95 in the 3D CRT. For the left lung parameters, we observed that the low dose region, that is V5, in 3D CRT was significantly reduced compared to IMRT with the value of 43.22 versus 70.61 respectively. Whereas the high dose region, that is V30, was significantly reduced in IMRT with the value of 15.67 compared to 28.99 in 3D CRT. The D mean was favorable in the IMRT group with a value of 14.12 compared to 15.87 in the 3D CRT group. Similarly, for the heart parameters, the V5 was significantly reduced in 3D CRT with a value of 24.45 compared to 60.85 in the IMRT group. Whereas the high dose region, that is V30, showed a significant reduction in the IMRT group with a value of 6.96 compared to 14.65 in the 3D CRT. The D mean in the heart was significantly reduced in IMRT with 9.62 compared to 10.08 in the 3D CRT. For post-mastectomy radiotherapy to the left chest wall, IMRT significantly improves the conformity, homogeneity of the plan and reduce the high dose volume of ipsilateral lung and heart compared to 3D CRT. But 3D CRT is superior in terms of low dose volume. IMRT compared with conventional or conformal radiotherapy technique for breast cancer has benefits in terms of dose, toxicity and quality of life. But there are issues in clinical implementation of IMRT, especially in post-mastectomy treatment, such as high cost, complex and time-consuming procedures, dedicated quality assurance program, and management of inter and intrafraction changes. Also, the consequence of higher low dose volumes, that is, the increased chances of second malignancy with IMRT, need to be weighted against the benefits of reducing high dose volumes on individual patient selection basis. In conclusion, the choice of radiotherapy in breast cancer is a very important factor in the protection of nearby normal structures and in the identification of associated risk. For this reason, the patient profile should be evaluated carefully and keeping in mind the available resources at the center, the method to be used should be decided accordingly. Thank you.
Dr. Anki Bakshi, you can stop sharing your screen now.
Thank you, Nanki. Now I will invite, should we take the questions right now or after the...
So we'll take at the end after all three presentations.
So I will invite the
Yes,
second presenter, Dr. Asma Siddiqui, who is a resident from TMH, and she will be presenting a prospective cohort study in breast cancer patients with new bone metastasis. So, Dr. Asma, can you please start your presentation?
Asma, you have been made the co-host. You can start sharing your screen, please.
Yeah, 1 minute. Am I audible?
Yeah.
Yeah, you're audible.
So, good morning, everyone. Topic of my thesis is prospective cohort study of breast cancer patients with new bone metastasis to estimate the risk of skeletal complications. And my guide is Dr. Professor Rajiv Sarin. So, coming to the introduction, as we know, bone is the most common site of metastasis in patients with breast cancer. Approximately 5 to 8% of the patient presenting with bone metastasis at initial diagnosis. It is estimated that 2/3 of the patient with metastatic breast cancer develop skeletal metastasis by the time of their death. In 47% of the patients, bone metastasis are the first site of metastatic disease. Now coming to the skeletal related events, which is a generic term which encompasses the complications or events associated with the bone metastasis. So the skeletal related events includes pathological fracture, spinal cord compression, hypercalcemia, re-radiation, surgical or interventional radiology procedures to prevent or treat symptoms or complications of the bone mets. The magnitude of the problem is a study by Plunkett et al. For breast cancer patient presenting with bone metastasis from a single institute in UK. So out of 1,437 patients, it has been seen that 28% have metastasis only to the bones. 37% patient develop pathological fracture during the follow-up. 17% patient develop fractures in the long bones, and 26% have hypercalcemia, and 15% have spinal cord compression. So the rationale behind the study was as there is no data on the incidence, nature, impact, and outcome of the SRE in any large Indian cohort. And the models for predicting SREs, particularly pathological fracture, were developed using the X-ray and the Mirel score. So this study will provide insight and impact data on the bone metastasis and clinical outcomes of evidence-based management in a contemporary cohort of breast cancer patients with bone metastasis in India. The study cohort includes our inclusion criteria is pathologically confirmed breast cancer and patients presenting with new bone metastasis, proven radiological or pathological, and the exclusion criteria is if they have received any treatment outside or unable or unwilling to give written informed consent or are not willing for the follow-up. So the primary outcomes are to estimate the skeletal related complication rate in breast cancer patients, which includes the pathological fracture in the appendicular and the skeleton, inclusive of the pelvic girdle and the shoulder girdle. The vertebrate compression fractures and fractures in the other bones will be noted separately. To clinically manifest the spinal cord compressions, procedures like fixation, stabilization, or vertebroplasty, re-irradiation of a previously irradiated site. So the secondary outcomes are identify factors predicting an overall survival of less than 6 months in this patient population. These are other factors, but I will be focusing on the first secondary outcome. So coming to the methodology, data collected using an CRF form from May 2018 to May 2020, eligible for at least minimum 6 months of follow-up. The demographic, disease and treatment related variables were recorded and the incidence of SREs are estimated. Actual rates of SRE calculated using the Kaplan-Meier method and the overall survival curve was estimated using the Kaplan-Meier method. And the factors predicting SREs were estimated using univariate analysis, and the multivariate logistic regression analysis will be done after completing the follow-up information. Coming to the patient and disease variables, 143 breast cancer patients with newly diagnosed bone mets were enrolled till May 2020. Age at diagnosis was 46, the mean age is 46.3. The range is 24 to 72 years. Now, if we can see out of the 143 patients in menopausal status, 73 were pre and perimenopausal and 70 patients were postmenopausal. Coming to the stage at initial diagnosis, we have categorized into OBC, LABC, MBC, oligometastatic breast cancer. So we can see the locally advanced and metastatic breast cancer patients were 47, 60. 60. And out of these, 65 patients presented with metastasis at the time of presentation. So we have divided into the like with molecular subtypes: luminal A, luminal B, enriched and TNBC. Luminal A have 75 out of 143 patients. This is the graph showing the same. Now coming to the distribution of the pain score at the time of presentation, we can see the pain score between 4 to 7 and less than 4 is more as compared to the more than 8. So now coming to the RT details, out of 143 patients, 85 patients have received RT when they presented first to the OPD. 21 patients received radiotherapy subsequently during their follow-up, and 37 patients did not receive RT at all. The most common site for which the RT required is pelvis, followed by the spine, and the dose fractionation which was used more commonly was 8 gray single fraction, followed by the multifraction, which include 20 gray in 5 fractions. So the median duration of the patient follow-up as measured from time of diagnosis of bone metastasis and date of last visit was 17.2 months. At the time of analysis in December 2020, 59, that is 41.1 patients have died. 50 out of 143 presented with bone metastasis at the initial diagnosis. 36 out of 143 patients diagnosed with bone mets have SRE, with a median time from diagnosis to develop first SRE was 26.1 month, and 8 patients had 2 events leading to total 44 skeletal related events. So the SRE developed is 36 out of 43 is 25% of the cases, in which the cord compression includes 21 patients, pathological fracture 5, re-RT was given to the 5 patients, and pathological fracture of the axial or flat bone was 5, and the 2 patients which includes the 2 events The cord compression is seen in the 2 patients, RERT for 2. Hypercalcemia was seen in only 1 patient, and pathological fracture for flat bone is seen in the 3 patients. So these are the Kaplan-Meier curve for survival of the patients with bone metastasis. So the median survival is 19.6 months with a 95% confidence interval of 16.1 to 23.1. The median 1-year overall survival from diagnosis of metastatic disease was 70.8 months. Overall survival after diagnosing the bone metastasis is 24.2 months with a 95% confidence interval of 21.2 to 31.2. This is the table which is showing the patient characteristics. We have divided into age group, menopausal status, stage, and the p-value was calculated using the chi-square test. For age group, it is 0.87. For menopausal status, it's 0.5. For staging, it's 0.78. For the receptor status, it is less than 0.001. For the pain score, the p-value is 0.03. For the type of metastasis like lytic, sclerotic, and mixed, it's 0.004. For the site of bone metastasis, we have divided into axial, appendicular, and both, which is 0.28. And the site of metastasis at presentation, which is skeletal only or skeletal plus visceral, which is 0.81. So this is a Kaplan-Meier curve showing the ER positive cases. We can see that ER positive cases had a higher SRE because they lived longer after developing the bone metastasis to develop the SRE. This we have compared with the ER positive patients compared with the other patients. So coming to the conclusion, SREs are common in breast cancer patients, especially those who live longer. In selected patients, preventive surgical and other procedure can prevent the skeletal related events, and SBRT or fractionated higher dose RT can be considered. Thank you.
Thank you, Asma. Now I would like to invite our third presenter, who is Dr. Ankur Mittal from Mahatma Gandhi Institute of Medical Sciences, Sevagram, Wardha, and he is going to present his work on treatment challenges of breast cancer patients in rural India, a retrospective study from his institute. Dr. Ankur.
Yes. I would like to request Asma to stop sharing her screen, please. Dr. Ankur, I've made you the co-host. You can start sharing the screen, please.
Okay.
You can take questions till then.
1 minute.
There is any issue.
1 minute, I'm sharing. Sorry for the delay. Yeah, am I audible? Hello, everyone.
Yeah.
Yeah. Good morning, everyone. Today in this webinar, I wish to raise my voice in the context of treatment challenges of breast cancer patients in rural India, a retrospective study from single institute. I have done this study under the guidance of my guide and HOD, Dr. Virender J. Vyas, sir. So firstly, starting from the introduction, majority of Indian population resides in rural areas, as we know. So in such areas, the health of the female and her preferences are neglected by the family members. Hence, the potentially curable disease like breast cancer led to 87,090 deaths in India in 2018 as per Globocurrent Statistics of India. In an attempt to search for the cause of negligence and delayed treatment, we have undertaken this study. Objectives of our study are to assess the breast cancer management challenges in terms of limitation in diagnostic investigation and treatment compliance regarding multimodality treatment approach in rural population of central India. Our study design is, this is a retrospective observational study of all patients diagnosed with breast cancer from January 2018 to December 2019 in a rural center of central India, in which information regarding ERPR HER2 markers status and mode of treatment received, that is surgery, chemotherapy, radiotherapy, endocrine therapy, and targeted therapy, followed by follow-up period of each patient, is obtained from hospital records. So our observations are the total number of registered patients of carcinoma of the breast while these 2 years were 314. Out of them, 46 patients in this rural area have received no treatment. And while 144 patients were non-compliant to adjuvant treatment. Among them, 16.8% patients are those who have received no adjuvant treatment, while 28.9% patients were those who defaulted during their adjuvant treatment, either it is chemo or radiotherapy. While 124 patients were those who have completed their multimodality treatment approach. Also, we have observed out of these 314 patients who were registered at carcinoma of the breast in this rural area, only 193 patients have done their immunohistochemistry 3 markers test. Out of them, 55 patients were triple negative, recognized as triple negative breast cancer, while 43 patients were recognized as HER2/3 positive, and 36 were recognized as HER2/2 positive. Those who were HER2/3 positive, that is 43 patients, among them only 9 patients have received trastuzumab in this rural area. And also among these 9 patients, none of them has received total 17 cycles of 1 year duration of trastuzumab. Only 4 patients have received 12 cycle, single patient has received 8 cycle after that defaulted, and 2 patients have received 6 cycle, and other 2 patients have received 4 cycle. And other is HER2/2 positive, 2 positive patients were 36. And in this rural area, as due to the lack of the FISH tests, as we know, for the HER2 positive patients, we need FISH tests to assess whether it is HER2 negative or it is HER2/3 positive. So we have missed the chance to know about the HER2/3 positive status of these 36 patients. So from this real world data, we may conclude that to improve treatment compliance in rural India, counseling of patients regarding multimodality treatment approach, that is surgery, and it should be followed by chemo, radio, targeted, endocrine, that all should be promoted from the day of diagnosis, and it should be instilled in the mind of the patient from the day of diagnosis only. That is it is a long duration of the treatment and it is a curable disease. So for that, tumor board discussions should be emphasized and documented at that time. At the second point is, for lack of FISH tests in our rural center is a diagnostic challenge and that should be addressed. Third point is, due to financial constraints in rural India, very few patients are receiving targeted therapy trastuzumab, as we have seen in our study. So this drug should be made available in government health scheme for cancer patients to improve survival of HER2 positive patient. So from this webinar, I want to raise my voice to state government of Maharashtra that under the Mahatma Jyotiba Phule scheme, that trastuzumab drugs should be made available for these cancer patients so that they can receive the targeted therapy, those who are HER2 positive. As we have observed in our area, the patient's willpower is strong, but due to the lack of testing and lack of drugs available in the government scheme, they are not compliant to a treatment and they are missing the treatment. So this is what from my side, and these are my references. Thank you for that.
Thank you, Ankur. Nice presentation and very important points you have raised. Many of our patients, they don't have enough funds to do the ERPR and HER2 test itself. So forget about getting the trastuzumab injections and maintenance therapy. So I will now like to invite our expert panel, Dr. Bhavin Visaria and Dr. Rima Pathak to join and give their expert comments. Meanwhile, we can take some questions. Dr. Rima has a lot of questions I can see. So Rima, can you please ask the questions? Rima, please unmute yourself. Rima. Dr. Rima, can you please unmute you?
Ma'am, you are muted.
Yeah.
Before I start asking questions, I just wanted to know if anyone else has any questions. Perhaps we should give them the opportunity first. Any questions from YouTube?
No, ma'am, there are no questions on YouTube. Just Dr. Bhavin had made a comment about mean heart dose being 9 gray, which is very high.
Yeah, so
Rima, I have a question for the first presentation.
Yes. Yes, Tabassum, please ask.
Yeah, so wanted to ask the presenter, I mean, why do you think is the difference in the lung doses, especially the low dose between 3D-CRT and IMRT? What is the metric which is higher in IMRT and which is lower in 3D-CRT, while especially for the low dose volume?
Because in IMRT, the whole concept is that each beam is divided into number of beamlets, and there is non-uniform fluence. Because of that, there is the integral dose increases, but then the low dose volume also gets more dose.
So, right, I wanted to hear the word integral dose. So, very good. And but can you also give us some detail about, I mean, what are the factors which are taken into account, which tells you that, of course, IMRT is definitely going to increase the integral dose because of the low dose pill. Do you know the formula?
Sorry, ma'am, but I'll read about it. But one way is that the MU will also increase.
Yes. And do you know amongst the available technique which is of IMRT, capable of IMRT, whatever IMRT solutions that are available, do you know which technique can lead to a lower integral dose? And this is one question. And what could be the other thing which you could have done to circumvent this this problem of low dose pill with IMRT?
Ma'am, one way is that we could have used the integrated field. That is that you take the SCF and that in one single field. So that will decrease our MU also.
Yes, the first question.
And that you take it as an integrated instead of a segmented field.
You don't just think about, I mean, only LINAC base. You think of other options also, which can lead to dosimetrical advantage of.
Arc therapy.
Yeah, Rima, you can carry on.
Bhavin, any comments?
Nanki, have you tried electrons for treating chest wall and 6 megavoltage for treating SCF?
We don't have electrons at our center, so unfortunately I couldn't.
So once you go out in your practice, private practice, so what will you recommend, 3D-CRT or IMRT to the chest wall patients?
Sir, personally, I would recommend conventionally a 3D-CRT plan, but if I think that the chest wall of the patient is convex or I could save the OARs much better with IMRT, then I would go ahead with IMRT. But my first preference would be 3D-CRT.
So do you have, so other than the convex chest that you said, do you have any other case scenario or any particular case in which you would like to use IMRT over 3D-CRT?
I'm in head and neck.
No, in breast only. I'm saying in post-mastectomy, other than a convex chest, which are the cases where you think that IMRT will be best suited rather than 3D-CRT? Are there any cases upfront you see a scan and say that this patient will probably require IMRT and not 3D-CRT?
For a shallower breast, or when I know that the OARs are very close to the
so heart.
chest wall. Heart, yes.
Do you also use DIBH? Do you have deep inspiratory breath hold technique?
We don't have it at a center.
Okay. I think I have a question for Asma then. So there was a question by Anil. What is the SRE rate in patients who did not require RT at diagnosis? So among the nearly 60% patients that you did not treat with radiation at the beginning, how many developed SRE? And could they have been prevented if you would have given radiation earlier?
Ma'am, the patients who have not received RT, in that 5 patients have developed SRE. So one patient had a incidental diagnosis of pathological fracture of the sternum. So patient was asymptomatic, hence we have not given RT. Rest of the patients were presented with poor GC. So we were not could not give RT to these patients.
Okay. And could you have prevented all of these SREs if you would have given RT at the beginning?
Yes, ma'am, we could have presented because the SREs were cord compression. So we could have prevented it if they have presented initially.
So we have to evaluate the patients better. Is that what you're saying?
Yes, ma'am.
Okay. And then why were your hypercalcemia rates so low? Does that mean that you've not taken patients with extensive bone metastasis in the study? Have you specifically excluded such patients?
No, ma'am. I was not able to calcium levels. I was not able to get because of that. I have to.
Okay. 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 And then my question to the last speaker is that is this registry based data at your hospital?
Yeah, ma'am, it is registry based data from my hospital. I have taken the hospital records of all the patients of 2 years. And then I
Okay, can you please switch off your Anil, can you please turn off? Yeah. So, Dr. Ankur, coming back to you.
Yes, ma'am.
So, why only 9 patients received trastuzumab? Are the government agencies not funding trastuzumab at your center?
Yes, ma'am. Actually, the patients are not affordable for the that trastuzumab, and in our center, the government health scheme is not providing the trastuzumab.
Are there any NGO agencies that you could perhaps liaise with to get funding for trastuzumab?
Ma'am, we have only the Sanjeevani Counseling Center is there. So from that we can try by and know about no other any agencies.
And then you gave us almost a staggering of 50% patients who defaulted adjuvant therapies.
Ma'am, your voice is not clear.
I'm saying a staggering 50% of your patients defaulted adjuvant therapies. Can you please clarify what sort of adjuvant therapies they defaulted? Was it just trastuzumab? Was it adjuvant chemotherapy? Was it adjuvant?
No, ma'am. Actually, I talked about the whole adjuvant treatment. Actually, what the patient have done, some of the patients have defaulted after MRM only, and some have defaulted while chemotherapy, or some after radiation and chemo. Some have defaulted for the targeted or endocrine.
Okay. So as a radiotherapy student, I was expecting a little more detail on how many patients defaulted radiation, what were the causes of them defaulting radiation, because as such, radiotherapy is not supposed to be a highly toxic treatment, fairly well tolerated.
Ma'am, actually, I was talking about the multimodality treatment. So as far I have seen in my hospital records, for the radiotherapy in the breast cancer, the compliance is good. But if we see about the whole treatment modality as a multimodality approach, at that time the compliance is an issue, and for that relapse may be an issue for that.
And what is the standard radiotherapy dose fractionation that you use for your patients?
Ma'am, the standard we use the 50 gray 25 fractions, but while the COVID crisis, we have started using the hypofractionation schedule of 40 gray in 15 fractions.
So do you think hypofractionation or reducing the number of fractions will help in reducing the patients that default treatment so that they don't have to spend more time at the treatment centers?
Yeah, ma'am, if they are very compliant to this hypofractionated regime.
So are you going to continue to adopt that as your standard practice post-COVID as well?
Yes, ma'am, we are going to adapt this and this thesis also has been made by my senior also in our center for the hyperfractionation comparison with the conventional and CA breast, and they have also observed that it is a non-inferiority trial. So we are going to continue this after COVID also.
Okay. Okay.
Okay. Thank you.
Bhavin, any comments? Bhavin, you're muted for some reason.
He's not muted.
We are unable to hear you, Bhavin. Are there any questions on YouTube till then?
He's not muted. Okay.
Are there any YouTube questions from anyone? Prachi?
Ma'am, no, ma'am, there are no YouTube questions.
Okay. Okay. Anyone wants to ask any other question from the people on Zoom? If not, I think we can conclude the session. So I think Bhavin is unable to join, at least his audio is unable to join us. So I would like to thank everyone. All the three presenters did a fantastic job. And we are really expecting that all of these three come out as publications, and we would like to see more details about everything. Yeah. And Ankur, I think, yeah.
I would like to ask if Dr. Vijay Palvi or Sharmila ma'am have anything to add to the session.
Thank you. Like nice presentations by all the presenters, and all the best for their publications.
Sharmila ma'am, ma'am, are you there? I think ma'am is not there. She, I think, logged out. So we'll move on to the next session, thoracic oncology session.
Dr. Nanki, there's a question from Bhavin for Dr. Nanki. What about opposite breast dose and LAD doses? Did you check them? Sorry to come back.
I did not.
Yes, Dr. Nanki.
There's a question
for Dr. part of my study.
Were you able to hear the question?
Yes, ma'am. Ma'am, the opposite breast we did not take. It was not a part of my study though.
Okay, but do you routinely use contour opposite breast for IMRT cases?
Yes. Ma'am, yes, ma'am, we do.
Okay. And are there any constraints that you commonly use? Maybe that will give us an idea.
For the contralateral breast, we use dose to 5% of the volume should generally be less than 1.3 grade, 1.3 to 1.8 grade, according to the RTOG.
Okay. And a question to Dr. Asma, any comparison between surgical intervention versus RT for newly diagnosed bone metastasis?
Ma'am, we have not done any comparison yet.
Do you have any patients who underwent surgical intervention?
Yes, ma'am. We have 2 patients only which presented with pathological fracture and require the fixation surgery. And we have given
presented with pathological fractures. Only 2 underwent
fixation. Yes, ma'am.
Okay. Okay.
There's a question for Dr. Ankur by Dr. Bhavin. If MPJ provides Herceptin, would you give 6 cycles versus 12 months?
What if Herceptin provides?
If MPJ provides Herceptin.
Yes, yes.
If any government aid is provided. Then.
Yeah. Yeah, that the duration should be completed for the 1 year, every 3 weeks apart. So we need to have with the total 17 cycles of trastuzumab if the patient is HER2/3 positive.
Okay, I think we can conclude. Vijay?
No, thank you.
We'll conclude this session. Thank you, Dr. Vijay Palve. Thank you, Reema Patak ma'am, and thank you, Dr. Bhavin Vasari and all the participants. We will start with a new session, the next session, thoracic oncology. I would like to invite the chairpersons for the session, Dr. Kaustav Talpatra, National Head of Department of Radiation Oncology, Kokila Ben Hospital and Reliance Cancer Hospital, and Dr. Vikas Kotwade, Consultant and Department of Radiation Oncology, Jupiter Hospital, Pune.
Hi, Vikas, are you there? Vikas?
Yes, Dr. Kosto, I'm there.
Vikas, you can start off. Yes, please
Okay.
start off.
I would like, sorry, sir.
No. Hello?
Yes, sir. So, yes, sir, please continue.
Do you hear me?
Yes, sir, we can hear you. So your voice is breaking, as in we can't hear you now.
Hear me?
Yes, sir, we can hear you now.
Yeah.
Am I audible?
Yes, sir.
Anyway, Vikas can take over later, I think. Vikas, are you there?
Yes.
I
think Vikas can't hear
Dr.
us.
Tehsin, he's presenting a retrospective study to evaluate the pattern.
Interesting talk, which will deal with the
Just a
margin.
minute. Both of you are talking.
You know that the cancer is great, and there is always we find the local failure also.
Vikas, can you remove your earphones and use the computer audio?
Should we call him?
In that event, I would like to invite Dr. Kasina.
If we don't give proper margin, if there is a failure within the CT margin, then we may have higher risk. Hello, I am audible?
Yes, sir, you're audible.
Okay.
Vikas, can you hear us?
Yes, ma'am. I'm able to hear you.
Okay.
Yeah. So should I continue?
Yes, sir.
Yeah. So this is a paper going to present and very nicely designed study. So let the presenter present. Then we Dr. Sarbani madam will give the I think Dr. Ashwati and Dr. Anil. These are the very good expert in this field. So they will give expert comments about this study. So I will ask the presenter to continue the presentation. Hello?
Yes, sir.
Yeah.
Good afternoon, everyone. The topic of my thesis is a study to evaluate the patterns of failure and its impact on the adequacy of CTB margins in patients who were treated with radical radiochemotherapy in esophageal cancer. So esophageal cancer is the 8th most common cancer in the world. A majority of the patients present with a locally advanced unresectable disease, which is treated with radical radiation therapy with concurrent chemotherapy. It is a highly locally aggressive malignancy, and 50 to 60% of the patients are seen to fail loco-regionally after radical treatment. The RT doses used worldwide are not uniform, and they range from a dose of 50.4 gray to 63 gray in 1.8 to 2 gray per fraction. There is also no consensus regarding the CTB margins, as in historically 5 centimeter margin to the GTB was given in the superior-inferior direction to delineate the CTB, but at present we use a 2 to 3 centimeter for the CTB. The primary objective of my study was to determine the patterns of failure in patients treated with radical radiochemotherapy in esophageal cancer. The secondary objectives were to assess the adequacy of CTB margins, to determine the local failure-free survival, the overall survival, and the progression-free survival, to evaluate the prognostic factors impacting survival, and to document the toxicity of radical radiotherapy. The inclusion criteria were all consecutive histologically proven cases of esophageal cancer who were treated with radical radiotherapy at TMC between January 2013 to December 2017. The exclusion criteria were patients who did not receive treatment at TMC patients who received neoadjuvant CT-RT or who had previously received RT to the thorax, and patients with a synchronous double primary were also excluded. It is a retrospective observational study. The data of the patient's treatment details were retrieved from electronic medical record, case records, treatment planning system, and radiation oncology information system, which we use here in TMH. 243 patients were screened, and of which 158 patients were found eligible. The cohort of patients could be classified into two groups. In the first group were the patients who were treated with the two-phase technique. In the first phase, they received radiation with APPA portals, which was followed by a boost with 3D CRT or IMRT in the second phase. And the other group of patients were those who received radiation in a single phase with either 3D CRT or IMRT alone. In the patients who were treated with a two-phase technique, in phase 1, the CTV was the GTV plus a 5 centimeter margin given supero-inferiorly. And in phase 2, the GTV was given a margin of 3 centimeter. The patients who were treated with a single-phase technique, for them, the CTV was defined as GTV plus a 3 centimeter margin in the supero-inferior direction. The patterns of failure was assessed by clinical examination and investigations such as RPGI endoscopy, barium swallow, CECT thorax, or a PET CT scan. The adequacy of CTV margins was assessed by comparing the UGI scopy reports at baseline and at the time of failure, and by registering the CT or PET CT at the time of recurrence with the planning CT scan. Coming to the results of the study, the median age was found to be 57 years. 91.8% of the patients had a squamous cell histology, 5.7% had adenocarcinoma, and only 2.5% of the patients had small cell carcinoma. The most common subsite was the upper thoracic esophagus, which accounted for 34.2% of the cases. This was followed by middle thoracic esophagus, which was seen in 28.5% of the patients. Cervical esophageal primary was seen in 25.3% and lower thoracic esophageal primary was seen in 12% of the patients. Coming to the results, 50.7% of the patients were treated with IMRT, and the remaining of the patients were treated either with a combination of 2D or 3D technique, 3D CRT alone, or a combination of 3D CRT and IMRT. The median RT dose used was 63 gray in 35 fractions. The range was 40 to 70 gray. The median GTV length was found to be 8 centimeter. 21 patients did not complete their radiation therapy, and further few more patients did not turn up for the first follow-up. These patients were excluded for the survival analysis, and out of 158 patients, 127 patients were analyzed. 41.7% of the patients had failure at some site. So here we can see the cumulative local failure rates were 69.8%. However, the isolated local failure was seen in 29.1%. The isolated regional failure was seen in 67.5%, and isolated distant failure was seen in 56.7%. 16.2% of the patients had a failure at all the three sites, that is, they had a local, regional, and distant failure. All the patients who had a local failure had failed within the GTV, that is, they had an infield failure. Out of the patients who had a regional failure, 68% of the patients had infield failure, 28% had an out-of-field failure, and 4% had a marginal failure. Here, when we describe a patient as having an infield failure, we mean that the recurrent GTV volume, the 95% of the recurrent GTV volume was within the 95% isodose line. Lungs were the most common site of distant metastasis, which was followed by liver and brain. A median follow-up was 45.8 months, and the median overall survival was found to be 21.1 months. The median progression-free survival was 14.7 months. The most common acute toxicities seen at the end of radiation treatment were dermatitis and dysphagia. In conclusion, the most common site of failure seen in our cohort of patients was local failure, and all the patients who had a local failure had infield failure. Hence, the 3 to 5 centimeter CTV margins, which we use in our institute, seems to be adequate. Thank you.
Ask Anil and Ashwati to give their expert comments.
Hi, Tehseen. Thanks. That was
Ashwati, can you please take over?
Yeah, hi, Anil. Thank you for the invitation. And Tehseen, that was a great presentation. And I'm sure a lot of hard work has gone into analyzing these failures. I'm just curious, did you find any prognostic factors? You mentioned that you would be doing regression analysis to find out any prognostic factors. Was there anything which was significantly related to your risk of local or regional or distant failure?
Yes, ma'am. Ma'am, for overall survival, local failure-free survival and progression-free survival, ma'am, the PNI, the prognostic nutritional index or the serum albumin was found to be, ma'am, significant in all three, both in univariate and multivariate analysis. Then, ma'am, for a progression-free survival, the PTV length was also significant, and both in univariate and multivariate again.
And you had a median GTV of 8 centimeters. That's quite quite a large volume. The other thing was, so patients who had, so you looked at all esophageal cancer patients during this duration, right? Okay. And what proportion of patients completed full doses? I think you mentioned.
And 20 out of 158 patients, 21 patients could not complete their treatment.
Okay. Was this due to toxicity or was it due to?
Ma'am, majority was due to toxicity. 2 or 3 patients had defaulted and a few had progressed, or 2 patients had progressed on RT. So the radiation stopped.
And what kind of chemotherapy was given? So that I didn't find any mention of
Ma'am, platinum doublets, and paclitaxel and carboplatin mainly. And for small cell carcinoma, it was cisplatin and etoposide.
Sorry.
Yes,
Anil, if you have anything.
There's a question in the chat box from Dr. Bhavin. As most of the failures are in the field, any role of dose escalation? What was the mean dose given?
The mean dose I found in my cohort was 63 gray in 35 fractions.
So actually it brings us to an interesting question of, even with 63 gray dose escalated doses, we are still having a vast majority of the failures in the field. So, I mean, I would like to put the question to Dr. Anil and Dr. Sharwani, I think, who's definitely listening in, as to, is dose escalation the way to go forward, or do you feel, I mean, of course, you're saying the 3 centimeter, you are restricting volumes now. So you're actually trying to reduce toxicity. But what do you think is the future going forward?
Yeah, so before I can comment, I can ask
Anil and Naveen answer that question.
Yeah.
I don't treat esophagus.
Yeah, so before I can answer, I'd like to invite Dr. Sarbani or Dr. Naveen. Is Naveen there? Naveen? So, ma'am, Naveen is there, but I think he's not
I know
able
I can
to
see him online, but
Yeah.
So if you want my opinion on this, we
Yes,
published
ma'am.
our first
Please.
cohort of retrospective patients, which was Mukesh's thesis, in which we did find a trend. We published this, and I think it's in a publication. It's not yet come out in print. So in that, we did find that there was a favorable trend towards dose escalation, actually, rather than the ones who received a lower dose. So the ones receiving 63 gray actually did better. So that's why it again takes me back to the issue that, dose escalation in squamous carcinoma of the esophagus, there I think is still there is still a role for it. How you choose to escalate that dose is a matter of debate. We've traditionally done it with external beam radiotherapy because brachy could be more toxic in this setting because we're using concurrent CTRT, but I'll let Anil take over to say what they have in mind now and whether they're going to go the escalation path or are they going to look at something else.
Yes, ma'am. Very good point. As you already mentioned that we have seen actually over the or the Southeast Asian countries that there is a dose-response relationship, and we have found in our study also that is hopefully will be shown that there is a benefit in overall survival for the dose escalation. However, unfortunately, we did not find that yet in the study by Tasina. So we need to slightly modify the dose escalation technique. Maybe we can use like a simultaneous integrated boost to reduce have a CTV margin, and then we can do, for example, 50 gray to the entire PTV. But that also depends upon your PTV length, because you will not be able to deliver approximately 60 or 63 gray to the entire PTV. So because the patient will have a certain amount of toxicity that might hamper his or her quality of life. So dose escalation is obviously is being questioned in various randomized control trials recently. So abstract has been presented by the Art Deco. In that particular study also, if you see, approximately 30 to 35% of the patient in the dose escalation arm still are failing within the GTV.
Yes.
So apart from the dose escalation, there is certain biological principle that is happening over there that the oncology community is still yet to find what are the reasons behind the local failures in spite of having the dose escalation arm. So I think we need to look it from a different perspective as far as the failures are concerned.
I think there's a Chinese trial also which was presented at ASCO, which also said the same thing. Basically, unresectable squamous cell carcinomas, they didn't find any differences in overall survival, local progression survival, or in the patterns of failure. So again, 80-85% failed in field local failures.
So there is a question by Dr. Rahul Walke for Tasina. So what is the consensus for now? So dose escalation versus CTV margins of 3 to 5 centimeter. I think he is going to. So what he meant is that, do you want to dose escalate or do you want to just reduce the margins?
So right now we are using a margin of 3 centimeter in patients who are treated with IMRT. So I think we can look further for those different methods of dose escalation.
No. So, but what is the consensus overall worldwide?
Consensus.
Are you aware of any contouring guidelines?
Consensus is a reduced margin right now.
Okay. Yeah.
I think it's at 3 centimeters currently. Whatever consensus guidelines have come out, it's for, especially for IMRT techniques and all, it is at around 3 centimeters currently.
3 centimeters, yes.
And dose escalation, at least based on, I mean, I know we all do it, especially in squamous cell carcinomas, but I mean, internationally, I think dose escalation is still at 50.4. So I don't know.
Yeah. So I think Dr. Vikas wants to make some point. So please go ahead, Vikas.
See, in the while you are giving the reducing the CTV margin, but you are aware seeing the PT margin will reduce because of availability of motion management, daily agility, that is okay. But when you are reducing the CT margin, so you are reducing the microscopic disease margin basically. So that time we should be very much certain that we are contouring the correct GTV. So for that, I think before concluding that we should be able to reduce from 5 centimeter to 3 centimeter, we should ascertain that we should able to use all armamentarium like endoscopic ultrasound and PET CT. And then we can reduce the margin from 5 to 3. It only based on the CT or the ultrasound results. It will be too early to reduce from 5 to 3. That is my opinion. What Anil you say?
So I think you have to let Tasina answer that question.
So normally we use a baseline PET CT and we fuse it with the planning CT to delineate the GTV. And we also use the upper J endoscopy findings so that to make sure we do not miss out any of the gross tumor.
Yeah.
Your study, how many cases you have done the PET CT?
So in my study, the 91% of the patients had a baseline PET CT that was used for treatment planning.
There was a paper in 2014 Trade Journal, I think. They shown that is cases of any CTRT, not definitive CTRT, and they shown that after surgery, if you give a there are the if the residual
मैंने दे दिया क्योंकि ड्यूटी इसके टाइम मतलब बर्थडे के टाइम पे इसीलिए नहीं तो कहां
the residual disease is beyond the CTV, then the overall survival has reduced from 80% to 20%, and if it is within CTV, then survival is around it's 1 year overall survival, of course. So I think that while reducing the margin, we should be very much certain because it's for microscopic disease.
Yes, certainly. So there is a comment from Dr. Bhavin to Dr. Ashwati. Can we have a dose escalation part as far as the proton beam therapy is concerned? Because we know that proton has a superior physical properties and the dosimetric aspect. So are there any RCT or any study which have shown that the dose escalation by using proton is beneficial?
So the randomized trial, the phase 2b3 randomized trial, which came out with protons, actually shows the primary endpoint was total toxicity burden as well as PFS. So both these co-primary endpoints, the tumor toxicity burden was significantly improved with protons. So the ongoing randomized trial, which is the primary endpoint is overall survival, is basically not looking at dose escalation. It is looking at the reduction in the toxicity rather than increasing the doses. So it's examining only standard doses. So that's why, because the USP of proton is toxicity reduction, most of the thrust is not on dose escalation, because dose escalation hasn't shown, at least in the Western cohorts of patients that they are looking at, it hasn't shown to improve outcomes.
Yes. There's a comment by Dr. Abhishek Chatterjee. Is there any update on the Art Deco data after the initial excitement? So I think the full paper is still not out.
Still only an abstract, I think.
Yeah.
And Anil, can I
Yes, sir.
speak something on
Sure,
the
sir, please.
cantina business? Vikas said it that to reduce, we should be careful. No doubt on that. We should be very careful. And prerequisite is how you can, gold standard at some point in life will be how you can image them ante-mortem so that your post-op or a post, the certainty factor is nearly close to 4. Means all your pre-treatment investigations should be such good that you are picking up even microscopic business. So that can be either done by a classical way of like a breast size, they did it, everything failed in that quadrant and very minimally in other quadrant. Okay, so that study you can run. The challenge here is another one. The challenge here is, since there is no serosa and lymphatics are freely moving here and there in the esophagus, and you can't escalate a dose to beyond certain dose, so you are concentrating everything on the present day gross tumor volume wherever they are failing, right? Because if you treat with a wider margin, you are ending up in increased toxicity. So certainly, you can make it 3 centimeters from 5 so that you have least toxicity and you can compete with a newer modality like proton, which are comparing toxicity. That is the only thing we can do. Even if you give 60 gray, most of the time you have given 60 gray plus, and still you are filling in the GTV, right? And whole of the world is stopping at 50, around 50 or so. So we should be concentrating how best we can help these patients to improve their PFS without increasing the toxicity. And I think towards that, you can reduce in a serial methods in a prospective fashion by a 2 centimeter or start reducing by a centimeter and then 2 centimeter and so on in subset of the patients with whatever standard sets of investigation you do.
So one more point in this matter is that there is a lot of effort going into combining radiation with other biologics. So
Agree.
targeted agents in order to radiosensitize and, without increasing the radiation dose, which might increase toxicity, to target the tumor cells better. There's some trials going on with immunotherapy. There's some with targeted biologics as well. So
I
that's another
completely
approach
agree.
that people are taking.
Completely agree. So another thought you can think in terms of the nodal failures. So the nodal failures, the moment you decrease your CTV at the primary, you need to really think about your nodal CTVs, which are going to be different, especially in N2s. Good, Tashina, good job.
Thank you, sir.
Good, Anil. Great assimilation of her thesis.
Yes, sir.
Basically, you are her guide only. I am the just
Are there any
Good.
comments from the audience or from Dr. Costa? Do you want to make a comment?
I have a comment.
Yes, ma'am, please.
If I may,
Yes,
because
ma'am.
I just heard Dr. JP suggesting that based on, you know, multimodal image fusion and improved knowledge about the actual location of the tumor, there may possibly be a scope for further reduction in margins. But you know, the data for margins in esophagus actually comes from pathological series about 3 centimeter. So I think it may be a little premature to actually reduce margins further, because as he himself said first, that you don't have a serosa, you have lymphatics traversing freely. So I think the margin reduction bit is a little bit of a challenge with esophagus. I know if you could reduce margins like in other sites, you would really be on top of, you know, trying to escalate further. So there is, I think we need to look beyond radiotherapy or beyond how we want to, you know, it's the biology that we have to take care of. It's biology that's again the king, you know, here rather than technology. So we need to see how we can do that, because just, so that's my comment. I don't know, I may be wrong, but that's how I look at the margins in esophagus actually.
So I agree that Sarvani, you are putting a caution, right? So we need to be cautious before we reduce.
Yes.
Uh, so what happens is your increased margin is secondary to your CTV, especially at the nodes, rather than in the primary. So whatever I think Tasina or Vikas was speaking was in classical less nodal bulk and not here and there. Maybe in N0 situation, you can reduce the primary CTV margin.
No. I'm actually talking about the primary and not about the nodes at all, actually, because the nodes are a different issue again in esophagus. I'm
So
concerned about the
I
primary.
know I understand your concern, but your submucosal disease, your lack of serosa issues, but we need to be very cautious. I completely agree, but we need to relook the time.
Definitely.
Good.
Because I think with time we've kind of
last
improved
hai na?
controls also. But
This is
you
the
know, at
last.
the same,
Sorry. So this
with
is the last
time,
presentation,
yes, I
Yes.
think so, yeah.
and we are in time also. Then okay, we can continue.
You know, because this is one disease where I think the increments in improvement, especially as related to disease outcomes, has been very slow. And it's not as good. You know, only the neoadjuvant CTRT has given us some ray of hope. But the definitive CTRT, we are yet to actually show a remarkable or a tangible difference. You know, so I think this is one disease that really deserves a lot of attention, because I think first we deprived our patients of the opportunity to go, and everybody still harps on the 50.4. But I think our disease is not the same. But yes, whether it's just physical dose escalation that's going to help or something else is difficult to say. But I really feel this disease is something that really still needs a lot of work to be done.
So a lot
Anil,
of
Naveen,
brainstorming, right?
yeah, lots of things that needs to be
So, ma'am,
Need study.
with respect to not reducing doses, not reducing margins, you can actually treat much more safer with protons without reducing your margins. So maybe
Yes.
that will help.
Yes, Ashwati.
Ashwati.
Yeah, of course, that remains to be seen. That's what
agree.
I'm saying. But I'm just, you know, like I'm just putting in a word of caution, because I'm a little, because I know we're not doing whole esophagus anymore. We are not doing those 5 centimeters. We're not doing T fields. We're not doing L fields. I don't subscribe to that also. But then further reducing physical margins, I don't know, you know. So I'm a little scared.
Sure.
You should always have a cautious thought, but still, let's put the best foot forward.
Yes,
Good.
we've been.
Hasina raised some issues among the colleagues. Good. चालू रखो.
चालू नहीं, खत्म हो गया ना?
नहीं,
Anil,
क्या
we're done,
करने
no?
क्या?
Yes, ma'am.
Good.
We are almost done.
Thank you for the first day and the second day and so on and so on. चालू रखो.
Sonali lunch.
Do we have any more comments? I would like to call Dr. Anuj to conclude the day 1 session.
Thank you, everyone. I would like to thank all the chairpersons, expert speakers, presenters, and participants who have joined from various places today for attending this session. So we will be continuing with the remaining sessions tomorrow. It will be starting at 9:15 a.m. with GI session, followed by Gynec, Uro, Hematolymphoid, and we will be selecting 2 of the best posters for oral presentation tomorrow. So I would like to conclude the meeting for today. Thank you everyone once again.
Thanks, Anuj.
Thank you, sir. YouTube. No, yeah. More.